what are the tips for mental health class? And this is what I'm going to be talking about throughout the 7 chapters. I think mental health also has 7 chapters. It does take a little bit of time to finish mental health too. So these are two most important and the biggest topics in NCLEX, maternity and mental health. Okay. So mental health is all about communication. How many of you agree with this statement that mental health is all about communication?
Yes.
Agree.
Agreed, right?
Mhm.
So if mental health is all about communication, should the nurses know how to talk to the patients? Right? I have lots of questions today from you guys. Can you tell the patient, don't worry about it, it's gonna be okay?
No,
No.
false
You guys
reassurance.
can,
False reassurance. No.
okay? You can't tell it. But have you told that to your patient ever?
Yes.
Right? So
Mhm.
things that we practice, we are more inclined to do those things. Sometimes students call me and they tell me, oh, but this is how we used to do things. And not necessarily what things we used to do are true, especially when it comes to communication. You're gonna see a huge difference in how you or I used to talk to our patients versus how we should be talking. And trust me, when I'm working in the field, sometimes I feel the urge to stop the nurse and tell her, hey, that is non-therapeutic, the way you just talk to the patient. So I teach University of Ottawa students in mental health, and I literally stop them when they talk to the patient non-therapeutically. I bring them back and I say, whatever you said to your patient, that was non-therapeutic. And they're like, oh, really? So non-therapeutic does not mean you made it like you committed a crime. It's just that you can't ask the patient why questions. You should not be asking the patient closed-ended questions. But what are those scenarios, two scenarios where you have to ask the patient a closed-ended questions? Anyone has any guesses?
Are you in pain? Yes or no?
Mm, no, not necessarily. It's not that one, but something big.
Safety issue?
Which one?
Safety issue. Are you in a safe place right now?
Safety issue, yeah. So suicide. Are you thinking
Mhm.
of killing yourself? Yes, no.
Mhm.
Something that you need the direct answer for. What about a patient with dementia? Will you ask them open-ended questions?
No.
Why
No.
not? Why not? Why can't we ask dementia patients open-ended questions? Please, guys, raise your hands. Answer, participate. It's okay. There is nothing wrong in being wrong. It's a learning lesson for all of you. So dementia patients, what do you think? Should you ask open-ended questions or not? If you should, why? If you shouldn't, why not? So,
Because their thoughts is not as like organized or they can remember things. It's gonna be hard for them to process right away. What are you asking?
wait. Is she? I agree.
Dementia patient have no capacity for the remember, right? So we can ask, can you do or do
Okay.
you want like affirmative we can use.
Okay. Mandeep, your hand is up too.
Not, I'm just want to ask that some of the students wants a link. They are messaging in group.
Okay. Okay. Okay, Parul, for the answer.
I think dementia patients are confused too, so that's why we should not ask them open-ended questions.
I'm looking for a word that will happen if you ask the dementia patients open-ended question. So I'll tell you. So dementia patient, as Ishi mentioned, they have forgetfulness. We all know dementia patients forget things, right? If you ask them open-ended questions, it causes a lot of confusion for them and it causes frustration because they forgot you like, how was your day? You went with your daughter. What did you do? So that's an open-ended question, but the patient does not remember. It can cause frustration. So it depends on the situation. We usually avoid dementia patients. If you guys work in long-term care homes, you must have noticed, let me get the students. You must have noticed that they bring two meal trays. They are like, do you want chicken sandwich or tuna sandwich? You're trying to decrease the choices that they have to make to avoid the decision-making fatigue. Okay, so we will talk about it a lot. Dementia is a very important topic in NCLEX. So we're going to talk about it a lot, dementia and delirium. So let's start our class. Mental health is all about communication. In non-psychiatric conditions, the treatment can be, so when you are in med surg, so Alveen is teaching you medical surgical, she taught you respiratory system, she is teaching you cardio. It's more about medications. It's more about drugs. Patient has a headache, you're like, okay, I can give a painkiller. Oh, patient is, have a bleeding, I'm going to try to control the bleeding, I'm going to check the vital signs. But that's not the case with mental health. Because mental health, you can't really see everything. The patient is having delusions, hallucinations, everything in his head. How would you know how the patient is feeling? Is by asking the patient, by having a communication. The patient's blood pressure is probably normal. Everything is fine. They have no temperature, no increased respiratory rate or anything. They're perfectly fine, but they have a mental health situation. So once we are able to administer a medication in medical surgical or perform a clinical interventions, it's pretty straightforward with med surg. But in mental health, part of the treatment and intervention centers around communication. That's why it's crucial to understand and use therapeutic communication. And today we are just focusing on communication. That's the only important topic I'm doing today. So that when you do, I did pick out a lot of questions from you world on communication because I wanted to show you guys how different questions come. And you don't even need to know the topic. It may say a patient has cancer, this. Which of the following is the most appropriate response? You don't even need to know the cancer. What do you need to know? How to talk to this patient. Okay. So know your interventions. Mental health class will include many diagnoses. What are the diagnoses in mental health?
Dementia,
Dementia, delirium,
Schizophrenia.
Alzheimer.
Alzheimer,
Alzheimer, dementia. Okay. Schizophrenia, depression, bipolar affective disorder, mania,
Mania.
ADHD.
OCD.
So many things.
OCD,
What else? Anxiety disorders, obsessive
Alzheimer.
compulsive disorder,
eating disorders,
eating disorders, anorexia nervosa, bulimia nervosa, dissociative disorders. So many things are under mental health. Okay. So we will be talking about a lot. Personality disorders. NCLEX loves personality disorders. Antisocial, narcissistic, borderline. These three personality disorders. So many of our students get questioned on personality disorders all the time. It's like you have to remember them, but I'm going to give you a technique to remember those two. So a lot of information from these topics that NCLEX like to test. Now, that don't all, so all the different diagnoses need different approaches. Your therapeutic communication techniques with a manic patient are entirely different from the therapeutic techniques you're using with a patient who has depression. You cannot use the same techniques. One patient is manic, other patient is depressed. Learn about interventions for patients that may include multiple elements such as nutrition. Nutrition is bulimia nervosa, anorexia nervosa, even manic patient. How would you make sure that they are eating? Schizophrenic patients are paranoid, suspicious, they may not want to eat. So you give them packaged food, the package that is sealed so that they are not paranoid and they will eat. Exercise. Why exercise? Because when you give schizophrenic patients antipsychotics, physical health is the most important component that you have to fix because second generation antipsychotics can cause diabetes mellitus. we will talk about it because second generation antipsychotics are connected to metabolic issues. They will increase the weight of the patient. They will increase the cholesterol levels. They will increase the triglyceride levels of the patient. And ultimately, this patient can be a pre-diabetic because of second generation antipsychotics like clozapine and all. There's so many names. We will go into that when we go there. Restraints are very important. Like, can you just, when I'm gonna give my experience example, when I was in India, you don't have to have an order. A patient is just moving the arm too much, you can restrain the arm. It doesn't matter, right? Like every single patient in ICU is restrained, but that's not the case. You cannot restrain patients without a medical order. You can't just take away someone's freedom in a free country without the permission of the physician. Okay. And you need to have a very solid reason why you want to restrain a patient. And restraints have mechanisms. So there are physical restraints, right? Physical restraint like wandering unit. If you guys work on a dementia floor in a long-term care home, you know that the door locks, right? Because people are wanderers. What is the meaning of wanderers? They're just walking around, and for their safety, they are on a unit which is locked. Okay, but of course, you need the consent from the family, but it's for patient safety. So patient safety is more important than the freedom of the patient at this time, because otherwise they're gonna go out, they're gonna get lost, they can sit outside in the cold, get a frostbite, whatever. Okay. So one size does not fit all, and understanding the conditions means understanding how to intervene well. Now, pharmacology, and I've already mentioned that it's so communication, interventions, pharmacology. And in interventions, it's ECT, electroconvulsive therapy, psychotherapy, also cognitive behavior therapy. All those therapies are important and they will be your interventions. How you intervene when a patient is very violent, what would you do? We call a code white. Okay, so I'm going to share my experiences because I work in mental health specifically. So I will be sharing my personal experiences with you, how Canadian healthcare system and mental health works. So pharmacology ties in. Remember that medications are not the only treatment. We know that medications are not the only treatment. We may have ECT, we may have cognitive behavior therapy, they may have group therapy, milieu therapy, family therapy, so many types. So medications are not the only treatment. It's important to learn all associated therapies too. Of course, many conditions do require medications. It's also important to learn the different medication classes and for which diagnosis they are used for. Okay. There are so many types of antidepressant, tricyclic antidepressants. Can you guys give me some? Monoamine oxidase inhibitors, MAO inhibitors. What else? Do you guys know any
TC,
SSRIs? Selective
TC,
serotonin, sorry?
TC,
Yeah, tricyclic antidepressants, MAO inhibitors, SSRIs, selective serotonin reuptake inhibitors, SNRIs, selective norepinephrine reuptake inhibitors. So there's so many kinds of antidepressants. Okay, we will talk about them in detail because they are very important. And the drug, one of the drug that the student wrote in the sheet that you guys got on WhatsApp from the question is actually an antidepressant. So be sure to know how they work, their mechanism of action. I don't know how other instructors do these things. I'm going to put my soul into this because I love it so much. Mechanism of action is equally important. If you don't understand why tricyclic antidepressants are different from monoamine oxidase inhibitors, you're going to mix them up. Okay, so we're going to understand how these different medications work, because if you understand how the drugs work, it's easy to pick up the side effects. Okay, so be sure to know the mechanism as well as how the medications interact with each other. MAO inhibitors and SSRIs can never be mixed. They cannot even be given like a week apart. There has to be 2 weeks gap, which is known as washout period. Okay, so we're going to talk about that. Be familiar with the antidepressant and antipsychotic medication classes along with which conditions they are used to treat. Now, last is safety, safety, safety. And safety is about suicide precautions because that is the another important topic NCLEX loves to test you on. You will hear that safety is always the number one priority. Well, it is. And it's not only safety of the patient. Whose safety are we talking about?
Nurse herself.
Nurse.
Nurse.
Thumbs up.
I want you, all of you, to remember when you are in a flight, whose mask are you putting on first? Your own. My safety is important because if the patient kills me, who's going to take care of the other patients? And I am important to my family too. I don't go to work to get myself killed. So my safety is important as a nurse too. NCLEX wants to know if you know this part. You know what I mean? This is not being selfish. This is being a professional. NCLEX doesn't want people to think, oh, you can sacrifice yourself. This is not war. This is not like, military. This is nursing. Your safety is equally important. As you learn about these conditions and answer any mental health questions, keep in mind that patients may be at risk of hurting themselves, which is known as suicide. Hurting others is known as homicide. Okay? Learn what things you can do as the nurse to keep you. Can you guys focus on this? To keep you and your patient safe. So you have to keep yourself safe and keep your patient safe. Safety first. Any questions from this slide? Anyone has? This is just like a very brief overview of what mental health is all about. And you can, just looking at this slide, you can imagine what questions are you going to get. You're going to get questions about therapeutic communication. You're going to get questions on restraints, and they come in the exam, like second part interventions. Pharmacology, you do get questions on mental health drugs. Number 4, safety, 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 suicide precautions, safety of the nurse, safety of the patient. Everybody feels okay? This is just the groundwork that I did for your mental health, okay? So now, before we begin, I have 3 videos to show you guys. I think I'm just gonna stop this share. I'm gonna show you all these videos one by one. Any questions for now, what we have just done? Okay, perfect. So let me take. When I teach the students of the university, these are the videos that we show to our students, and I like to share it with my students too, because like these are free for everybody, but this is how we teach them about mental health. So I'm going to teach you in the same way. The first video that you're going to see is for psychosis. And what is the meaning of psychosis? Schizophrenias are remember we talked about psychosis yesterday a little bit? Postpartum psychosis. Psychosis means hallucination,
Hallucination,
illusion.
delusion.
Okay. So there are different hallucinations. How many types of hallucinations?
5.
5.
How do you guys know there are 5 types of hallucinations?
5 senses we
Five
have.
senses.
Senses.
Five
What are the
senses.
5 senses? What are the hallucinations for 5 senses?
Auditory.
Auditory.
Sorry, one by one, guys.
Auditory.
Sorry, one
Touch.
by one. It's gonna get mixed up. So one by one. So raise your hands if you can. Let me see. So Mandeep, your hand is up. I hope it's not to tell me that the student is in the waiting room.
No, it's not now. It's visual, auditory, olfactory.
What else? You got it. So
Yeah,
before
and
you
for the
tell me the
tactile,
hallucinations, I want you to think about your senses. Okay.
the
You can
eye,
see. You can see visual. You can smell
olfactory,
olfactory. You can hear
auditory,
auditory. You can taste things. Gustatory. You can feel things. Tactile.
Tactile.
Okay, that's how I want you to remember them. Okay, so I'm going to share the screen. This is a very cool video. Please make notes because I asked a lot of questions after this video. Let me see if the sound is already shared. I think share computer sound. Yeah, let me see. Let me know if you can hear it. There is no sound yet. Please read what's written. It's important. Andy is a 21-year-old university student who is seeing a psychiatrist due to concerns raised by his GP. GP is general practitioner, like an MD doctor. He is in the final year of his degree and lives in a shared house with friends. Okay. So once the volume starts coming, please let me know if you can hear it because I will do the shares thing. Hi, Andy. Do you want to come on in and have a seat? Can you hear?
Yeah.
Yeah?
Yes,
Okay,
yes,
perfect.
Yes,
I probably will pause the video too sometimes to bring your attention to something. And I want you to know that these are actors. Okay. So of course, you can't breach the confidentiality of people. So all these patients, this physician are actors, but they are so good that you will believe them. Okay. So let's do the video. I'm Dr. Taylor. I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum. And I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. I know it's a British accent. Please read the captions. Okay? If you find it difficult, please read the captions. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay. That must be very difficult for you.
Yeah.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out what was happening?
I came home one time and moved the TV to the other side of the room.
Right.
And I knew then.
And what was it that you knew at that moment?
That they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni, and he works for MI5.
Right.
And he basically drafted my housemates in against me.
Okay. Yeah. Okay. Now I've noticed a couple of times while we've been talking that you sort of look round you into the room as if you're checking for something. Could I ask you what's happening at those times? So she's asking him that when you're talking to me, I noticed that you're looking in the room. Can I ask you, what are you looking at? What are you guys suspecting? What must be that?
Hallucination.
Hallucinations. Okay. It could be hallucinations. It could be visual or it could be auditory. He's going to answer that. Because psychosis is all about hallucinations. I want you guys to pick on these things. I'm going to send you all these links anyway, so that you can, like, during your break, I know you don't have a lot of break, but during one day that you have, you can watch these videos again. It will solidify your schizophrenia. When you learn about schizophrenia, psychosis is the most important component of schizophrenia.
Oh, I can hear him talking.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And did it sound real, like my voice sounds talking to you now?
It's odd. It's like I can hear them when they're not here.
Right.
And
so when they're not in the house with you?
Yeah, it's like they're in the other room or something.
Okay.
Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything I'm doing.
Right. Can you give me an example of what it would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like you left the house now.
Okay. Okay.
You know.
Anything else? Do they ever talk to each other, perhaps, about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them.
Right.
And they're saying like I'm making trouble.
Okay.
And they're going to sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah. I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. I'm not thinking.
So different thoughts in your brain.
Yeah,
right.
It's stupid stuff as well. It's like the other day, I suddenly just started thinking about some woman in Coronation Street. I don't watch it.
Right. It's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening? Or who's responsible?
It's MI5. It's this chip they put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts to your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay. Just
get this thing out of my head.
You mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and I can feel it moving around, like rotating.
You can feel the physical sensation in your brain. Okay, that must be very difficult for you.
Did you hear that? That must be very difficult for you. What kind of expression is that?
Empathetic,
or
like
empathy? Empathy. Whenever someone
empathy.
says that must be very difficult for you, they're putting themselves in your shoes and feeling how you must be feeling. So rather than saying, oh, I'm so sorry you're feeling this way, that is sympathy. But saying that must be very difficult for you is empathetic response. Okay, so be empathetic. Don't be sympathetic. When you're sympathetic, you're victimizing the people around you. You're like, oh yeah, something bad happened to you. That's on you. Like, I'm so sorry that your life is messed up, right? Stuff like that. So the better way to say is that must be very difficult for you. That must be frustrating. Things like that. Okay. So there is that's what we are learning. There is no point watching this video if you don't catch from this. So she was asking about, do you think that somebody took out your thoughts and you didn't even tell them what your thoughts were and they knew? She's talking about the term thought broadcasting. Sometimes schizophrenic patients will tell you, whatever the TV is telling, my thoughts are on the TV. Okay, so that's a terminology. I'm going to teach you mental status examination and we're going to talk about that. And then she said, did this ever happen that you stopped having all the thoughts altogether? That is known as thought block. Okay, so there are a little bit of terminologies involved. I'm just making you aware of it. I'm not asking you to remember it right now, but that is my way to tell you that please pay attention. This is an important video. You will get all the links. But this is what you're looking at. So what kind of delusions or hallucinations he has? He's paranoid. Okay. So he's paranoid. When people are paranoid, like you will see in his case too, where if he's so scared of his roommates, because he thinks they are planning against him, they are trying to hurt him. What is the risk? What can happen? When you're so scared of someone, you want to protect yourself. Okay? He may kill them because he thinks they're plotting against him. So she will ask him, how is your history with violence? Anytime, sorry guys. Anytime a patient tells you, I am paranoid, or like, somebody is doing this to me or they are doing this to me, you have to be very careful because now you are assessing the patient for risk of violence. If somebody is trying to kill me, I'm going to protect myself. I'm going to kill that person first. And you will notice this in this video. I am telling you this beforehand so that you can look for it. Okay, so I will pause it when it comes.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine.
Right.
I'm not ill or anything.
Okay.
Just want this thing on my head.
Okay. But it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I'm not really leaving my room much. And so I have to wait till they go out to go down and get some food. But they've been doing stuff to my food now. So
okay. What do you think's happening to your food?
They're poisoning it.
Right. Okay. Are you actually eating much at the moment?
No.
Okay. And with all this happening and this sounds like you don't feel very safe, have I got that right? Okay. Have you felt the need, I don't know, to take steps to protect yourself in any way?
Well, I've got a knife.
Okay.
And got a baseball bat. It's just in case they get in my room. I don't want to hurt anyone. I just feel like I've got to protect myself. It's like cornering me to do this.
Right, okay. Have you felt the need to use either the knife or the baseball bat so far? Take it out with you for protection?
No, I don't want to get caught.
Okay.
It's just in my room.
Okay. Has it ever got so bad, Andy, that you felt the need to hurt yourself or even kill yourself as the only way out, the only way of coping with this?
Right. It's not about getting some pills, but I couldn't leave the house. So I didn't get anything.
Oh, and when you say getting some pills, would that be to take an overdose of tablets?
Yeah.
But you've not actually done anything about that so far? Okay. In the past, have you ever had any problems either with your temper or getting into fights, being aggressive, either with your housemates or anybody else?
No, I'm not that kind of person. I don't want to hurt anyone. It's just driving me to this.
And can I just check again, you've not been in trouble with the police or anything like that?
No, never.
Okay. With all this that's going on, is there anywhere at the moment, Andy, that you feel safe?
Did you guys notice that he looked on the other side? Did you guys pay attention to that? I'll just, if you didn't, I'm just gonna bring it a little bit backwards. Okay. So he's looking in the other direction. Can you guys see?
Yes, ma'am.
That's what, like NCLEX will give you option. Patient is looking in a vacant space in the room. Okay. So this is a pretty cool video. That's why I'm showing it to you. Because he keeps looking around. He's not looking at the doctor. He's looking around.
Anywhere at the moment, Andy, that you feel safe?
My parents' house.
Right, okay. And have you seen much of your parents recently?
Yeah. It's not about going back there, but I don't want to drag them into this. I don't want them to know about it.
And throughout this last couple of months, when you've had all these worries, have you ever worried that your parents might in some way be involved in this conspiracy?
I thought about it, but no.
Okay. Can I just check out a couple of background things with you, Andy? Your general health, is that okay? You generally fit and well?
Yeah, not ill. There's nothing wrong with me. It's just this thing in my head. And
you're not on any regular medication from your own doctor at this stage?
No, I don't take any.
Okay.
pills.
What about other drugs? And by that I'm meaning alcohol, cannabis, pills, anything else?
I don't drink much alcohol.
Right. Okay. And what about drugs like cannabis?
Is my mum going to know about this?
No, I think it's important that I hear about. This wouldn't be something we'd be discussing with your mum.
Smoke a bit of weed.
Okay. Would that be regularly, so most days?
Yeah.
And how much would you be spending on weed?
Yeah, it'll be like a 10 bag it lasts a day or so.
Okay. So you have a 10 bag lasting you a day of weed. Any other drugs? I'm thinking in particular things like speed or pills.
Got a bit of speed.
Okay. Is that on a regular basis, Andy?
I just go out with my mates for the weekend and do a bit of more.
Okay. When was the last time, Andy, that you would have had any speed?
About a week or so ago.
Right. Okay. Any other drugs at all?
No. 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 But I know what you're getting at though. It's not the drug.
Right.
It doesn't matter how my face I get. It's constantly there. It's always there.
Okay. I guess the reason I was checking, I think it's what you picked up on, is that sometimes when people are having the kinds of experiences that you are, they find if they take certain drugs, it can make things feel a lot worse. I just wanted to check that hadn't been your experience.
No.
Okay. I appreciate from what you're saying that you're really very worried about this MI5 conspiracy and that's the cause of the difficulties that you're having at the moment. I just wanted to check with you, do you think it could be due to anything else? I mean, I've obviously met other people who've had similar experiences and sometimes they're extremely stressed. Some people might be actually mentally unwell. And just whether any of these things might be relevant to you at the moment.
No, because I'm not ill.
Right.
It's them. And I've read books on this as well. The government know about them.
Right.
They know that they do this to loads of people. I don't know how they can get away with it. I've done nothing wrong. I don't know why they're doing this to me.
Okay.
Okay.
Sure. And I think I can appreciate that. I guess what I'm wondering is whether you think there's anything that someone like me might be able to do to help you as a doctor, that sometimes meeting with someone like a psychiatrist or having medication, or for some people even coming into hospital for a short time might be helpful. Do you think any of those things would help you at the moment?
I don't know. I mean, I'm only here really because I'm a woman.
Right.
I don't want to worry her. I've tried to talk to her about it.
Yeah.
She doesn't understand. She doesn't really believe me. I mean, do you believe me?
So he asked her a question, do you believe me? The answer she's going to give is going to be an eye-opener for you guys because it's not a yes or no answer. Okay? So
believe, Andy, that you're having a really difficult time at it.
So she's saying, I certainly believe, Andy, that you're having a really difficult time at the moment. Right? Is that true? Because you can't give false reassurance. You can't tell the patient, oh, yeah, I believe you. Okay? Because
I guess what I'm not as sure about is what's causing this.
So what did she say? She said, I certainly believe you are having a difficult time. Is that a true statement? Yes. He's having a difficult time. He's not going out. He's not eating. He's living with his parents. He's scared. He thinks his food is poisoned. He's hearing all those voices. His life is messed up. Okay. But she's saying, I'm not so sure at what's causing this. I believe you that you're saying that I'm not sure if MI5 is the reason for your problems. So she is presenting the reality to the patient. Okay. So it's very important to...
I'm less sure this is due to MI5. I guess what I'm wondering is if perhaps you're not as well as you might be at the moment. I mean, we've been through a lot of questions, and what I'm thinking is we need to try and come up with a way of supporting you through this. So I'm wondering, because I know your mum is, I think she's waiting in the waiting room, might be a good chance now to get your mum in. And then perhaps the three of us can put our heads together, have a bit of a discussion about where to go from here, and try and think of getting you some proper support. Would that be all right?
Okay, so she was asking for the consent, and he will say yes, of course. How was the video?
Very good.
It's good. Very good, ma'am.
Very good, right?
Really good.
It's a very good video, and it's an eye-opener to see actually. I'm just doing psychosis today because I thought about if I do 2, 3, then you guys will be so confused, like what is happening, what was the first one, what was the second. But I'm gonna post all the links of all 3 videos for you guys, okay? Okay. Just bring my presentation. Any questions about the video? Anyone has any questions that, oh, I didn't understand this part, why did they do this, or something like that?
Ma'am, I don't understand the like drug history. Like he
Yeah,
said, he
good
take the
question.
weed or speed something. Is it was drugs?
Yeah, so that's a very good question. So what happens is, I'll share my experience. So I work at the Royal Ottawa Mental Health Center in Ottawa, and we have a schizophrenia unit. Since Canada legalized marijuana, our patients in schizophrenia unit increased. Okay, because people who have like a predisposing history, like genetics or some involvement with schizophrenia, but it's not full-blown schizophrenia yet. If they do these drugs, that can actually lead to a full-blown schizophrenia for these patients. So that's why she was asking about the history of drugs. And speed is amphetamines. Amphetamines, like that just makes, speed means that just speeds up everything for you. You're like very hyper after taking amphetamines. Versus if you take opioids, alprazolam or benzodiazepine, which are sleeping pills, you feel relaxed and you sleep. Okay, so these are just the different types of drugs that people use, and they do have a connection with schizophrenia. And when I teach you schizophrenia, you will know that's really true. Okay, so I'm just gonna share my screen with you guys. Okay, can you guys see my screen? Are you guys able to see?
Yes, ma'am.
Okay. Okay. Something is so wrong with this today. Okay. So we did we did this already. We did the videos, but I'm gonna do more videos in the coming time too, whenever we get a chance. Now, therapeutic relationship. What do you guys understand by therapeutic relationship?
Like how to communicate with patient?
Nurse-patient professional relationship.
Professional relationship, nurse-patient relationship. So that is therapeutic relationship. Now, of course, therapeutic relationship, therapeutic communication is very important. So I'm just going to zoom it in for you guys. There are do's and don'ts of therapeutic communication. Okay, what you can do when you're talking to the patient. This is from Christine's slide too. You guys can see it. So do's: allow the patient to control the discussion, except if the patient is manic, because manic patient will just run with the conversation. Also, when you have a narcissist, I'm not going to actually tell you guys these things yet because that will confuse you. So let's just go with the list. Allow the patient to control the discussion. Give recognition or validation, not advice. What is the terminology for advice?
That would be like saying personal suggestion, like I would think you should do that.
Yeah, that is
Or you
advice.
should do
You should do this, you should do that. That is advice. Should. Okay. Engage in active listening. Use open-ended questions. Provide therapeutic touch if it's appropriate for the situation. You can't just touch every patient. You need to know if it's appropriate for the situation and also culture. Okay. Use a calm, clear voice. Focus on the patient and their feelings, not your own. Paraphrase, restate, summarize. So, like the doctor has paraphrased the conversation so many times. So this is what you're saying. So Andy, this is what you mean. So you're telling me your friends are like this. So paraphrasing meaning summarizing. Whatever you're telling me a whole story. What I do in the end of the class. That's what summarizing or paraphrasing is. To like just compress it all together and say, okay, this is what we did today. Now, what are the examples? Is there anything you would like to talk about? That is a broad opening. We want the patient to control the conversation. Tell me more about that. tell me more is a very good statement, but NCLEX is not going to give you an option saying tell me more directly. You have to read the statement and understand that this statement is exploring. Okay. So you are saying you haven't been sleeping well. So paraphrasing or anything, tell me more about, like, these are the words we like to use in therapeutic communication. Now, don't ask why questions. I asked you yesterday, why can't you ask why questions? If you ask your kids, your partner, why are you late? How do they react? Mad? They don't like you asking that question. If someone asks you, why were you sitting there? How do you feel? What the hell? Why would you ask me that? Right? So why makes you feel defensive that I have to defend myself? Why automatically puts the blame on you? When someone puts the blame on you, you have to defend yourself. Okay? So ask an excessive amount of questions is known as probing. Like asking people to make, it's like probing is like you just keep poking the person. So yeah, oh, why didn't you get married? Oh, why don't you have kids? Why? You guys have been married for 10 years, 15 years. Why did you do that? Why? Like all these questions. Do not ask probing questions. Okay. Give advice, of course. Giving false reassurance. Don't worry, everything will be fine. How do you know? Right? And I give the students example of if a wife is going for a C-section and the husband is worried and you say, oh, don't worry, she's going to be fine. He's an amazing physician. And the wife actually dies on the table. Right? So you have to think about, don't just say, don't worry, you will be fine, because you can't predict the future. You don't know what's going to happen. Giving false reassurance, change the conversation topic. When the patient is talking about something, oh, I couldn't sleep last night, and you ask, did you have visitors this weekend? Because I'm filling my checklist. I'm not even concerned what the patient is telling me. So another thing I want to tell you, in real life, it's really hard to not change the topic because sometimes the patients just want to talk to you and you don't have the time. But for NCLEX has the perfect world. If the patient wants to talk to the nurse, NCLEX has all day for that patient to speak to the nurse. So they just want to know what is book perfect. What would you do if the situation is perfect? Give approval or disapproval, like, oh, I really like the green shirt on you. I don't like the black one. So you don't say that to the patients. Use close-ended questions or statements like, don't worry, like stereotypical statements. Oh, everybody feels like that sometimes, so it's okay. Okay. Don't talk about yourself or your experiences. Oh, sorry. Okay.
Anji,
Sometimes, sorry.
Anji Vajiki.
Beyond, I'm just going
Anji.
to mute you, okay? Okay. So I know how you feel when my mom was diagnosed with cancer. So sometimes we do share our personal experiences with the patients.
Sorry, ma'am. I forgot.
It's okay. So sometimes we do share our experiences with the patients, but just talking about you is not good, because who are you there for? For the patient. The patient is not there to listen about your story, because you cannot burden, even though the patient wants to listen to you, you cannot burden with your own worries to the patient. I think I have worked in like Canada for the last 10 years, and I've seen nurses having a beautiful relationship with the patients. But the problem is now the patient's like, oh, how is she doing? She was so worried about her husband. Poor her. She's so nice, but he's not. So don't do that. That's now the patient is worried about you rather than about their own health. Okay. So that's non-therapeutic and unprofessional. So don't worry, I think you should, don't be silly, that's great. Don't use these kind of words. Explanation for the types of communication. So how much communication, I don't know why this, can you guys see this when this does like kind of erase things around? Yeah, I don't know why this is so weird though. Okay, this is gonna try to, okay, now it's fixed. I don't like it. I'm like, why is this doing it? Okay. So how much communication is non-verbal? I give example to all the students every single time I teach. I tell them, when you go for a wedding or a party, you see people, you're like, oh, this person does not like me. They don't even talk to you. They didn't talk to you. They didn't say hello to you. And you're like, oh, I don't think they like me. How do you know? Non-verbal. How people
Yeah.
react to you, how people look at you, that's how you know. That is non-verbal communication. Okay, so non-verbal communication plays the most important role, and almost like verbal is only 5 to 10% of the communication. The whole communication is non-verbal, because even how you talk to people, your tone. Can you tell if somebody is mad? Can you tell from their tone that they are upset with you? They didn't tell you I'm upset with you. They just talked in a different tone. Okay. So nonverbal is ability to communicate and provide comfort without using the words. Example, nonverbal is like body language, sitting with your patient, facial expressions, eye contact, posture, vocal cues, yawning. Yawning tells me you're not interested. Tone of the voice, pitch of the voice are all nonverbal. Therapeutic, helpful, and conducive communication methods for healing, trust, and relationship establishment. So therapeutic communication helps with the when you validate the patient's feeling, like that must be really hard. Using a soft, calming voice, paraphrasing and restating, and open-ended questions are therapeutic. Non-therapeutic communication, that anything that blocks the conversation is non-therapeutic. Okay. The patient's like, can I talk to you? And like, no, I don't have the time to talk to you. Okay. Anything that just does not let the patient feel validated. So I think there's a video on Instagram that the marketing team, I made it a long time ago. They just posted it now. And in that, I talk about that how should you answer the questions. And one of the points that I mentioned was any option that make the patient feel less of themselves, any option that makes the patient feel unworthy or ignorant, that the patient doesn't know anything, I am the best, is a wrong option. So don't pick that option. Okay. That's what we are learning today. Even if I don't know the topic, if I know therapeutic communication, I can answer the questions. So asking why a person feels something, talking about yourself, I already told you, you can't burden the patients by talking about yourself. Using close-ended statement, except suicide, dementia, when the patients are not able, like it depends on the situation. Those are the primarily important situations when you're allowed to use close-ended questions and your answer won't be wrong. Changing the topic is non-therapeutic. The patient is talking about something else and you want to know, what did you eat for breakfast, is non-therapeutic. Like, because he wants something to be addressed first and you're talking about something else. Active listening, act of listening intentionally and engaging with the speaker. Like you guys are actively listening to me, you are engaging with me, you are intentionally listening to what I have to say because you're like, oh, this is important. Okay. Nodding, making eye contact, people who are off camera, except them. Okay. Maintaining eye contact, using the phrases like, I understand, that must make you feel. Written communication, helpful for non-verbal patients. Expressing emotion or communication with another person by writing the words. Like journaling, we use it for some patients who do not like talking. Sending letters or notes to others. Writing therapeutic notes to your former self. This is a kind of healing therapy. Creating list and schedule, writing notes on a whiteboard. Motivational interviewing, leading a discussion with helpful cues or questions for a patient to reflect upon and answer. So these are like communication techniques from the therapy part. Asking leading conversation with, how does that make you feel? What are the positive and negatives of this? What would you like to change? What seems to help? Can you help me understand this better? I'm just telling you that these are the motivational interviewing words that we use with the patients. Okay, that's good. Next slide is from UWorld. I have my own too, but I just took it from them today. So therapeutic communication techniques, listening, we just talked about it, an active nonverbal process that involves receiving and interpreting. Example, lean forward, maintain eye contact, and nod appropriately. Restating. Restating means restating. Stating is statement, speaking. So repeating the major theme, you say that your coworkers never invite you to lunch. So a person is telling you a whole story and then you picked up the major theme. Oh, that means you didn't enjoy the party. Somebody tells you, oh, I went for a party, there was this, the food was like that, the dance floor wasn't good. And then you say, oh, you mean you didn't enjoy the party. So that is a major theme, right? Like they're telling you the food is not good, the dance floor is not good, I didn't like this, that. And what is the major theme? That I did not enjoy the party. Okay. So I'm just giving an example. Broad opening, a statement that allows the client to choose the topic of discussion. What are you contemplating now? Meaning thinking now. What are you planning to do? So that is a broad opening. What would you like to talk about today? That is a broad opening. Clarification, asking the client for further explanation of a vague or confusing comment. I'm not sure I understand. Could you please repeat that? So when you don't understand what the patient is seeking clarification is like you guys ask me, ma'am, can you please tell me what you mean by that? That is clarification. Can you please clarify that? Reflection, repeating back the feeling, idea, or message conveyed. You are feeling anxious because of your job. So you're reflecting, you're asking a question. Sharing perceptions, stating an observation or summation that the client can validate or reject. Another thing, sharing perception is, she saw the patient. I just noticed you looking in the room. That, what is that? That is, I am sharing that I saw you looking in the corner of the room. That is sharing my perception. Which perception? My visual perception with you. The patient can tell, oh no, I was just looking at something. But this patient, Andy told her that I hear voices. Okay, so that's what it means. You say that you don't care, but I sense that you are upset. So this is just like an example in a different format. Suggesting offering alternate options. Have you considered using sleep hygiene techniques? Focusing, using statements to encourage exploration of a particular topic. I think we should talk more about the pain you have. So focus. Focus means zoom in on the patient's concerns. Theme identification, exploring overarching or repeated topics. I have noticed that you fear areas with crowd. I am gonna give you guys more example about what Uwald is saying, but these are just some examples how it can come across therapeutic communication techniques, how you can say things to people. So therapeutic relationship is an interpersonal, like between two people. It is client-centered. It's all about the patient. It's not social or reciprocal. What is the meaning of social or reciprocal? You can't make your patient friend on Facebook. Okay? Don't ever do that. That is a big, like I've seen so many people doing that. Don't do it. It's very dangerous. Okay? Reciprocal. What is the meaning of reciprocal? The patient don't owe you anything. You are taking care of the patient doesn't have to take care of you. Okay? So reciprocal means I'm like, we are not friends. It's not a social relationship. It's a professional relationship. So involves attending behaviors, caring and active listening, non-judgmental attitude and honesty. Did you notice the non-judgmental attitude and honesty with the doctor and Andy? She was so non-judgmental. He's telling her, I have drugs, I have knife, I have this and that. But she was still honest with him towards the end that I don't think that all these problems are because of MI5. Okay. Purposeful, goal-directed relationship that is directed at advancing the best interest and outcome for the patient. It's all about the patient. Components are trust, respect, empathy, power, and professional intimacy. So there are phases, orientation, working, and termination phase. In the orientation phase, the nurse goes to the patient and tells the patient, this is my role. This is our relationship, and this is when it's gonna end. The nurse will assess and plan regarding what are the patient's needs, what are the goals, right? When and where to meet with the patient on the unit, and limit and termination of the relationship. So this we do in orientation phase. So every nurse in the hospital, like we all become primary nurse for a patient, especially in mental health, we become the primary nurse. If I have Mr. Smith, consistency of care, right? That's why if I know a patient and that's my patient, if I have admitted the patient, I know the history of the patient, I have built up the relationship with the patient, I become the primary nurse of the patient. Working phase, problems and needs are identified and explored. This is the phase when we are trying to help the patient. Therapeutic techniques to reduce the anxiety and revise the goals if needed. You made the goals in the orientation state, and then we revise the goals if we need to. Termination, patient may become anxious because you are terminating, you are leaving, right? So patient may become anxious and react. Establish reality of separation. These reactions are discussed with the patient. Goals are evaluated for attainment. So the goals that you made in orientation, the goals that you worked in the working phase, and in the termination, you will evaluate those goals. Next is communication tips. Consistently focus on the patient's ideas, experiences, and feelings. Identify and explore the patient's needs and problems. So this is not to remember, but to understand that this is our goal. Discuss the problem-solving alternatives with the client. Help to develop the client's strength and new coping skills. So everything is about who? The patient. Encourage the positive behavior change in the patient. Assist the client to develop a sense of autonomy and self-reliance. What is the meaning of autonomy? Or autonomy or autonomy? What is autonomy? This is such an important term. NCLEX will ask you, which of the following statement tells you that this is autonomy? Google the word autonomy and tell me what is the meaning of that.
Just the freedom of taking the decision.
Sorry?
Freedom.
Autonomy, freedom.
Having the control.
Sorry, Mel?
Or having control or something you own. Something
okay.
that,
Yeah. Yeah. The patient should have a sense of control that I can do it. It's mine. And self-reliance means I am responsible. That is what the meaning of autonomy and self-reliance is. You don't want the patient to be dependent on you. Portray genuineness, be genuine, empathy and positive regard toward the client. The nurse practices empathy by remaining non-judgmental and attempting to understand the client's actions and feelings. Okay. Okay. So next is like it's a little bit different with the children and older adults. Is your hand up now or is it from the previous? So children use simple, straightforward language. Be aware of nonverbal because kids can pick on the nonverbals way faster than adults. As children are sensitive to nonverbal communication, when you're talking to a child, sit down. If the kid is 4 or 5 years old, sit down on your knees on the ground and talk to the child at the same level, like the eye level. Be at the eye level, incorporate play in interactions. What does that mean? If you are planning to take the blood pressure of the child, so usually like the pediatric units have all the toys. Nowadays, Lego has brought, I think the new concept was MRI Lego. So kids who were gonna go, so there is a CHIO in Ottawa, Children's Hospital of Eastern Ontario, like one of the best places to work. It's among the top 10 places. So CHIO has the Lego set, which the kids can build before they go into the MRI. How cool is that? Like they will see how it will happen. So that is the meaning of incorporating play in interactions. Giving the kids the BP cuff. Okay. When you go to the pediatrician's office or something, you notice that they have stuff for the kids to play with, okay, so that they feel comfortable. Older adults may require amplification, minimize distractions, and face the client when speaking. When I say minimize distractions, close the door, because anybody who's passing by will distract them. Turn off the TV when you're talking to your patient. They should have their visual glasses. If they're wearing a hearing aid, give them the hearing aid. Think about it. Think about all the components that can just improve the communication with your patient, so that you are not frustrated, the patient is not frustrated, so that you understand what the patient is saying and the patient understands what you're saying. Allow plenty of time for the client to respond, because they are slow. Okay. When impaired communication is assessed, ask for the family for input. Ask the family, how can we talk to, mom? Like, how can we talk to her? What are the things she responds to? And the family will tell you. Family sometimes brings, if you have like a different language, family will bring a board and they will tell you breakfast means this, lunch means this, stuff like that. Okay. Because that will decrease the frustration. Now, professional boundaries is CNO's very major standard. That's why I'm telling you, like, even if it's not just Ontario, College of Nurses of Ontario, just in general, professional boundaries are very important. And if you breach professional boundaries, there's consequences that you have to pay. So relationship changes from professional and therapeutic to unprofessional and personal. That's why we said nurse-patient relationship is not social, not reciprocal. You can't take out your patient for a coffee. Okay, you can't. So the misuse, who has the power? Patient or nurse?
Nurse.
Nurse.
You may think the nurse does not have power. We have lots of power. Why? Who has the medications? We do. Who has the right to call the doctor? We do. When you're working on the floor, you are the powerful people. Okay? Even the doctor thinks you have more power than them because you are the nurse on the floor. Okay. So an RN is a very powerful role. Misuse of power does not even have to be intentional. Negligence is a word, is when you did not do the action you were supposed to do, or when you did something you were not supposed to do. Intentional or unintentional, it doesn't matter. Negligence is negligence. So misuse of power is misuse of power, even if it's like intentional or non-intentional. Some of the terms we use, like, oh, it was never my intention. My intention was pure. It does not hold in the court. So it does not matter what your intention is, true or false, because anybody is going to be like, yeah, the mistake happened, but that was not my intention. Anyone can say that, even if they had the intention or not the intention. So intention does not matter. It's just the end result. Did you misuse your power? Yes or no? That's it. Okay. Do you guys understand what is the meaning of intention?
Yes.
Okay. So crossing a boundary, when you're like, oh, I didn't know I was going to cross a boundary. It doesn't matter if you did not know. That's on you. Okay. So when they give you standard, it's like the equivalent is what a reasonable and prudent nurse would do in the same circumstances that you were in. That's how they compare the things when you make a mistake. So limits set on professional versus personal behaviors of nurses. Define the role and responsibilities of nurses. It is the nurse's responsibility to maintain the therapeutic boundary, not the patient. Patients have no right, no duty to maintain a therapeutic boundary. Patient can ask you for your Facebook account. The patient can ask you that they want to follow you on Instagram or wherever. But who can maintain a professional boundary? I have to. Okay. So boundary violation examples. How do you know the boundary has been violated? Demonstrating favoritism or possessiveness. Oh my God, that's my favorite patient. Like when in the real world, we all like some patients because they're easygoing, they're chill and it's all cool. But you can't just show it to everybody like, oh, I love this patient. I just want this patient and nobody else should be the nurse of this patient. I want to take this patient. That can't happen. Okay. Feeling others do not understand the patient as well as you do. That's an example that you are violating a boundary. Disclosing personal information or contact information to a patient. Never give your phone number to the patient. You have breached a boundary. Okay. Spending off-duty time with the patient. You cannot spend off-duty time with the patient, even if you're trying to be nice and you're like, oh, I was just trying to be nice. That was not intentional. It does not matter if it's intentional or unintentional. It's a breach of the boundary. Frequently thinking about a patient when you're off duty. Oh, I wonder what the patient is doing. That is breaching a boundary. Red flags. Withholding patient information from the team. Oh, you cannot withhold any information from the team. Encouraging a patient to talk to you instead of other team members. Oh, you should always share all the information with me. Don't tell anybody anything. That is also boundary violation. Disregarding hospital policies when working with the client. Giving less care and attention or denying services completely to a specific patient. Avoiding a patient is also breaching a boundary. Okay, so it's not that you can't be very lovey-dovey with the patient. You can't avoid patients too. You can't argue with the patients too. Intense emotional reactions to a patient, like being aggressive with the patient, is also boundary violation. So after this, we have few questions and then we will take a break. So barriers to communication. What are the barriers? Asking irrelevant personal questions from the patient. Okay. Offering personal opinions. I think this is what you should do. Nobody cares what you should do. Giving advice. Don't give advice to the patients. Giving false reassurance. Minimizing feelings. Oh, it's not gonna hurt at all. Like, it's okay. I did this and it was okay. No, right? Everybody's different. Changing the topic. Asking why questions. Offering value judgments. Oh, this is good. This is not good. Excessive questions, also known as probing. Responding approvingly or disapprovingly. I approve this, I don't approve this. Any questions about this part before we move into questions? Everybody's feeling okay? It's pretty straightforward, simple, right? Some of these things must be like an eye-opener for you. Did anyone has any of the eye-openers? Like something you're like, oh, I never thought it like that. No one? You guys all knew about therapeutic communication. Okay. We'll find out. Okay, can anyone read the question for me? This is from you, Will.
Yeah, a client who is diagnosed with a breast cancer asked the nurse, am I going to die? Which statement by the nurse promotes a therapeutic relationship? First, cancer is no longer a death sentence. You may live for many years. Second, we'll ask the chaplain to come and talk to you sometime today. Third, many people with the cancer experience fear of dying. Tell me about your concern. Fourth, tell me about your life. What are your hopes and goals for the future?
Okay, all right. So therapeutic relationship, write your answers in the chat. I see 4 answers. I also want to know why the others are wrong, right? I know you guys are picking the right one, but why are others wrong? Okay, so many of you have answered 3, which is great. Okay. Cancer is no longer a death sentence. You may live for many years. What is
False reassurance.
false reassurance?
False reassurance.
Someone's mic is like too much background noise. Please check that. You guys can answer with me. That's okay. But somebody is talking in the background or there's a TV or something. Okay. I think it was, I will ask the chaplain to come and talk to you sometime today.
It's like ignorance.
Yeah, it's like that's not completely ignorance. It's like you did not even acknowledge me. I'm telling you, am I going to die? And you're telling me the chaplain will come and talk to me. Did you answer my question? Like, are you saying what's gonna happen? Are you exploring what I'm feeling? I might not even be interested in a chaplain. I don't talk to any chaplain. Why are you telling me the chaplain's gonna come talk to me? Okay? So think about it. Now, many people with cancer experience fear of dying. Tell me about your concerns. Yeah. That's true. Many people with cancer experience fear of dying. That am I gonna die? Tell me, what are your concerns? So you are acknowledging it. You're saying, yes, you have these concerns. Those are genuine. But what are your concerns? What are you thinking about? Sometimes people are like, who's going to take care of my family? Who's going to take care of this? I have this and that. That's how you will direct the conversation. Okay. Tell me about your life. What are your hopes and goals for the future? I'm telling you, I'm going to die. And you're asking me, what are my hopes for future? That is changing the topic. Make sense? Everybody understand? So the nurse, even option 2 could be true, but you should first ask the person whether they want a chaplain or a rabbi or a spiritual or some Buddhist or something. You don't even know the cultural background of the person and you're like, oh, chaplain's going to come. I don't want to talk to a chaplain. Okay. So a little bit more and then because I have my own slides too. So communication, therapeutic and non-therapeutic. So therapeutic communication, listening to and understanding the client while promoting clarification and insight. Goal is to understand the patient's message, verbal as well as non-verbal, to facilitate verbalization of feelings, meaning to help the patient in verbalizing their feelings. You acknowledge them and you ask them, tell me more. Okay. To communicate understanding and acceptance and to identify problems, goals, and objectives. So now there are some techniques that we're going to do. Let me see. Okay. So I think after this, I have lots of questions, but we're going to take a break after we finish therapeutic. So there are terminologies that we use when we are talking. So focusing, what is the meaning of focusing? I know you saw it in the very first slide from Yuval, but these are my own slides and it's from a book, Townsend. I don't know how many of you know about Townsend. Anybody knows what is Townsend? No? Okay. That's a book I was doing my master's in mental health. That's why this is from there. So focusing is, what is the meaning of focus? When you have a phone, you focus on things. What do you mean by that? So you pick one single idea and you zoom on it. So taking notice of a single idea or even a single word. Also, when the patient is moving rapidly from one thought to another, you're focusing, you're helping the patient focus. Now, what about the anxious patients? Can you focus when the patients are anxious?
No.
No. For anxious patient, you should not focus until and unless the anxiety has subsided. It's not a good idea with the anxious patient because they're already worried. They're already anxious. So now you want them to talk more about it? No. Okay. So you feel, so this is just examples. If you don't understand the example, it's okay. But this is just like, that's how they give the example. You feel angry when she doesn't help. This point seems worth looking at more closely. Perhaps you and I can discuss it together. So the patient told a scenario and the nurse focused on that the patient is feeling angry when someone's not helping. So the nurse is like, okay, let's talk about it, how you feel about it. Okay, so that's focusing. Exploring, you all know exploring, tell me more. You just did a question on tell me more. Delving means going deep into further a subject, idea, experience, or relationship, especially helpful with the patient who try to stay on a superficial level of communication, who don't want to tell you more. If the patient chooses not to discuss further, refrain from pushing or probing, it creates discomfort. Please explain the situation in more detail and tell me more about the situation. But if you notice that the patient is getting uncomfortable and they don't want to share more, you got to stop, because then it becomes non-therapeutic and is known as probing, which is excessive questioning. Exploring is good, tell me more, but if the patient's like, no, I don't want to talk about it, that's it. Okay. Seeking clarification and validation. Clarification when you are unsure of what the patient is saying. The patient said a confusing statement. You're like, I don't know what you mean. Can you help me understand this? So striving to explain something vague or incomprehensible or confusing and searching for mutual understanding. Clarifying the meaning of what has been said increases understanding for both client and nurse. I'm not sure that I understand. Could you please explain? Tell me if my understanding agrees with yours. This is what I am understanding. Is this true? Do I understand correctly that this is what you said? So we are seeking what clarification. Okay. Sometimes you guys do this with me. You're like, this is what I understood. Is this true? And I say yes. Sometimes I say no. And then I provide more clarification. Presenting reality. When the client has a misperception of the environment, the nurse defines reality or indicates his or her perception of the situation for the client. I'll tell you what. So the guy thought that, his friends are talking. So what can you say? I want you to know hallucinations when the people have misperceptions, because perception is what? Perception is all the senses. How you perceive things. You perceive things, you see them, you hear them. So misperceptions are actually hallucinations. When you have a patient who tells you that, oh, I see people, I see people walking around, people are dead. So I shared this story with you, with my previous batches too, and I'm going to share it. I had a patient who used to see dead people walking around, visual hallucinations. Imagine how difficult it is for the patient. You think about it, empathize with the patient and think about it. Like if you see walking dead people around, it's so uncomfortable. It's so bad, right? You may not see it, but the patient sees it. Okay. You can't tell the patient, oh no, I don't see anything. You can tell the patient, it must be very difficult for you, but I don't see them. You can present the reality. It must be frustrating to see all those things, but I don't see them. So one of our patients used to hear 3 different voices in the ears. There was a drum, there was a drilling noise, and then there was a third one. Think about when I'm talking to you and you hear these 3 different voices, how distracted you will be. It's very uncomfortable for the patient. So you have to be empathetic. So example, look at this. I understand that the voices seem real to you, but I do not hear any voices. There is no one else in the room but you and me. What are you doing? You are presenting the reality. You can only present reality with hallucinations, not with delusions. We will talk about delusions. Delusions are different than hallucinations. Hallucinations are 5 senses. Okay? Hallucinations are 5 senses. Voicing doubt, expressing uncertainty as to the reality of the client's perception, often used with clients experiencing delusional thinking. Did you hear the doctor say, I know it must be very difficult. What was the sentence, the last sentence she said? It must be very difficult. I know you're having a very difficult time, but it is hard for me to believe that MI5 is the cause of all these problems. Did you hear that from her? It was towards the end she said that, because he was thinking all the problems are because of MI5. Do you believe me? Okay. Do you guys remember I paused the video when he said, do you believe me? And I paused it and I told you guys, listen to this answer. So voicing doubt. Sorry? Okay.
Yes, ma'am, we remember. Like, I don't understand what is the MI5. It was like chip, like something.
MI5 is Mission Impossible, the movie MI5.
Oh. Okay.
Oh, I'm sorry, guys. I didn't realize you guys. I know sometimes it's hard to, connect these. I'm sorry. I should have said that. Good thing. And now I get the feedback. And next time I'm going to tell the students MI5 is Mission Impossible 5. So verbalizing the implied means what the patient was implying. What is underneath? Like, sometimes you can read between the words, read between the lines. So putting into words what the client has only implied or said indirectly can also be used with client who is mute or experiencing impaired verbal communication. This clarifies what is implicit rather than explicit. So, you can feel what the patient wants to say. Are you feeling this? It must have been very difficult. So sometimes the patient is not telling you directly how they feel, but they're just telling you indirectly. So you can tell them, are you feeling this way? Is this what you mean? Okay. Attempting to translate words into feelings. When the feelings are expressed indirectly, the nurse try to de-symbolize what has been said and to find clues to the underlying true feeling. So sometimes the patient say, oh, I feel like I'm just here out in the ocean. I'm just, swimming in the ocean. That means the patient probably feel they are alone. So that is what attempting to translate words into feelings. Okay. We don't do all of this, but like it's good to know information. Formulating a plan of action. When a client has a plan in mind for dealing with what is considered to be a stressful situation, it's good. Formulating a plan of action. Next time you're angry, this is what we're gonna do. Okay. So what could you do to let your anger out harmlessly? Formulating a plan of action. What is my plan of action? If I get too bored with my studies, what am I gonna do? You guys should formulate a plan of action too. If I get too tired of studying, what am I gonna do? What is my plan of action? Okay. So using silence, we already talked about it, gives the client the opportunity to collect. So when you use silence, it gives the patient an opportunity to collect their thoughts and think to a point and, just take in the information and just tell you more. Okay. It's very difficult to use. My students had such a hard time using silence. They're like, ma'am, I didn't know how to just stay silent. I just kept talking to the patient. So you have to give the time to the patient. Silence, like just stay there. It's okay. I know silence is so uncomfortable and we all want to fill in the silence, but it's good. Accepting conveys an attitude of receptivity and regard. Yes, I understand what you said. Giving recognition to the patient, acknowledging, indicating awareness, better than complimenting, which reflects the nurse's judgment. So we just did a question when the patient's like, oh, I think I'm going to die. You have to acknowledge the feelings of the patient. Okay. Next, this is the last slide before the break. Offering self, meaning giving time to the patient to make the patient feel worthy that I am available for you. Making oneself available on an unconditional basis increases the client's feelings of self-worth. This is mostly helpful with the patients who have depression. Even if your patient does not want to talk to you, you have to go and sit in the room for 10-15 minutes. Even if the patient is not talking. Would you do that though in real life? Yes, you have to. You know why? That is the plan of care. So when you read the plan of care, every patient has a care, you guys talk about care plan. Every patient has a plan of care and it's written, spend 15 minutes with the patient every 2 hours. Because depression patient is not going to come out of their room. So that is offering self. You tell the patient, I understand, like you're not willing to talk to me, because depressed patient will not talk to you. They will just sleep in their room or they'll just sit alone and nobody, and trust me, when I was in India, depressed patient, you don't have to worry about because they don't want to talk to you. You don't want to talk to them. It's like, okay, that's fine. But no, that's not how it is. You have to spend time with the patient. You just have to sit with the patient. Giving broad opening, we talked about it. What would you like to talk about? Okay, let's talk. What is the topic of interest for you today? Allow the client to take the initiative in introducing the topic of their choice. Emphasize the importance of client's role in the interaction. You're telling the patient, you control the interaction. Tell me what you want to talk to me about today. What would you like to talk about today? Tell me what you're thinking. Offering general leads like, okay, yeah, keep going. That is encouragement to keep going. We all do that. Okay, that is, okay, keep going. Placing the event in time or sequence, that means you are saying, okay, you ate the breakfast, then you went to the gym, then you did this, that. So that's like sequencing the events. Making observations, verbalizing what is observed or perceived. Making observation. I made an observation too. I told you, look, the patient is looking on the side of the room. That is making observation. This encourages the client to recognize specific behavior, and they will tell you more why were they looking in that direction. Okay. So next is non-therapeutic communication. I am thinking I should give you guys break, but let me see when is the questions coming. Okay, so we have 1, 2, 3, 4 questions after 4 slides, but I'll give you the break and then we'll do the questions together. Okay, where is that? How is everyone feeling? Did you think about mental health in this way? Or is it like easy, simple, or confusing?
Yes.
Yes, ma'am.
It's simple,
Yes,
right?
good.
So the goal is like, know a lot of this stuff, but it's just to give you a different perspective that this is how you have to think. So that when you pick your answers, like now, if I ask you the question, I think Puneet asked me yesterday in the chat, right? Puneet, you're like, how was the question about how can the parent help the mother? If you guys have to do that question now, would you think it differently? Do you guys remember the question I'm talking about? It was in the chat for maternity. How would you participate how would you encourage the participation of the dad? Now, if you have to look at that question, is your mindset different than what it was? Because everybody answered, oh no, the mother baby time is quiet time, all these. I want all of you, can someone write this and can we talk about that question for a minute? Let me see. My phone is packed, so I'm looking for the question. Okay, so it's yellow. I'm gonna resend it, okay, in the group so that you guys can see it now. Okay, so this is the question I'm talking about. The partner. Oh, I think people can't see who are not in the group. There are some students who are not in the group. So how do you feel about this question now? Okay, let me share my screen with you guys. So this is the question, right? The partner of a client who is caring for a newborn wants to be involved in the newborn's care during feedings. Which recommendation should the nurse make to the partner? How do you read this question now? What is your thought process? Many of you picked which answer?
Fourth.
Fourth, right? Many of you picked 4. And some of you have picked number 3 too. 1, 1, 3. I think if I go to the poll, I can tell who picked what, which. Now nobody's trying to answer. But if you look at this question now, what is your mindset? Are you more kinder? Are you more nicer? Are you thinking, oh, I have to help this dad to get involved in the care because that is therapeutic? Are you understanding what I'm trying to teach you? That you have to have an open mindset when you're reading this question. The partner of a client who's caring for a newborn wants to be involved. If he wants to be involved, that's a good thing. What's the harm in involving a parent? Okay? During feeding, which recommendation should the nurse make to the partner? Are you going to tell him, realize that breastfeeding time is a mother-baby time? That does not help the partner to get involved. Bring the infant to the mother for the feeding times. Is there any harm? No. But would it engage the parent? Yeah.
Yes.
Right? Recognize that there is little that can be done during the feeding time. Like we know he can't do much. He's not asking. He already knows that there is not much he can do, but he's asking you, how can I help? Right? How can I help? You tell him, oh, there's nothing much you can do. That is mother-baby time. Or we need to maintain it quiet. How do you think about this question now? It's not about the question. It's not about the answer. It's about your mindset. Make sense to everybody?
No. Yes.
Your nonverbals are much appreciated. Okay. All right, guys. Have a good break. I will see you guys after the break. Let's come back at 8. Okay. I'm just going to pause the recording before I forget. Okay. So next, we are going to move on to non-therapeutic communication. And we have already discussed these terms. I'm just going to show more examples of the same. So giving reassurance is usually false reassurance. Indicates to the client that there is no cause for anxiety, thereby devaluing the patient's feelings. When you use the words like, I wouldn't worry about that if I were you, it doesn't matter if you wouldn't worry about it or not. You can't give someone false reassurance, like everything will be all right. It's better to say, we will work on that together. Because when you give false reassurance, it discourages the patient to express their feelings because they're scared that, oh, the nurse thinks everything's going to be okay and I'm worried she's just going to judge me. So patients don't express their feelings. That's why giving false reassurance is not the good way to go. You should explore their feelings. What are they feeling? What is the reason for them feeling scared? Rejecting is refusing to consider or showing contempt for the client's ideas or behaviors. When you don't want to talk about the patient's feelings, this will also tell the patient that the nurse does not want to talk to me, and they will not share feelings with you because they're scared that you're going to reject their feelings. So this is again non-therapeutic. Approving or disapproving, we already talked about. It's like signing or denouncing the client's idea or behavior. When you tell the patient, that's good, I'm glad that you did this, that's bad, I would rather, like, it's better to say, let's talk about how your behavior evoked anger in the other clients at dinner. For example, the patient got angry with someone else at the dinner table in the dining room, in the unit dining room. And you go to the patient and say, that's really bad. I didn't like it that you fought with other patients. Rather than saying that, you can say, let's talk about how your behavior was perceived by the other patients in the dining room. Things like that, because that is more valuable. And it also shows that you are not telling the patient that if you're behaving well, only then I am your nurse. If you're not behaving well, I don't like you. So those kind of feelings, approving or disapproving, is in that context. Next is giving advice. Telling the client what to do is never good. You should never give advice to anyone. I give advice to you guys too, but you should never give advice to a patient. Telling the client what to do or how to behave implies that the nurse knows the best and that the client is incapable of self-direction. So what are you trying to promote in the client? Autonomy, right? Remember, all of you Google the word of autonomy, means self-reliance. So if you are giving advice, the patient's going to be like, where is my nurse? Oh, I want advice again. Should I call my nurse? So you want people to make their own decisions based on their own situations. You want to make the patients independent. So don't give them advice. I think this is what you should do, because when you're not there, now they feel incapable of making those decisions, because they'll be like, oh, when I was in the hospital, the nurse was helping me make all these decisions. I don't know who to ask for help now. Probing, we already talked about. Persistent questioning of the client, pushing for answers to issues the client does not wish to discuss. Tell me how your mother abused you when you were a child. If the patient doesn't want to talk about it, stop. Better technique is recognize the client's response and discontinue the interaction at the first sign of discomfort. So I'm going to share one thing with you here. I get lots of calls throughout the day, right? One of the students, and you guys know that Alberta has the best rules like before the end of April. So Alberta had the easiest rules, and so many of you received eligibility through Alberta. So the student actually lives in Alberta and she works in a long-term care home as a healthcare aide. So she called me, not our student, not in your group or anything. And I'm not going to breach the confidentiality anyway. I'm not going to say the name. So I asked her, I'm like, oh, Alberta had the easiest rules. How come you missed it? She was like, there was too much going on. Yeah. So if I keep asking her, why did you miss it? Why did you miss it? Is it going to make her feel better? She missed it. It's gone. You can't keep probing and make people feel bad about something. So I was like, oh, you know what? It's okay. If it's missed, we still have another option. We can still apply for Nova Scotia. I'm just giving an example. You guys don't have to think about the filing and anything, but don't make people feel uncomfortable when they don't want to discuss something. Okay, so that is my example for you guys. Even with your friends, if they don't want to discuss things with you, if they don't want to tell you if they have written the exam or not, don't keep asking, why did you fail? What did you do? Because there could be so many reasons. Not everyone wants to discuss everything in their life with other people. Okay? So respect that. And that's why probing is non-therapeutic. Now, defending is like, defending other people. So sometimes, and we all have done it. Oh, the doctor is amazing. Who are you defending? The doctor. You can't defend other people. Okay. So attempting to protect someone or something from verbal attack. Oh, this hospital is amazing. We don't do that. That's non-therapeutic. No one here would lie to you. If you tell the patient, oh, nobody here would lie to you. Do you know? What if the morning nurse lied to the patient? You don't even know. You only talk about yourself. You don't talk about other people. So you have a very capable physician. I'm sure he only has your best interest in mind. You don't know what if the physician makes a mistake in the OT, operation theater, or the OR operation room. You don't know. So you only talk about your own self, not trying to defend other people, because that shows the patient that they have no right to express their feelings of how they feel about other nurses or doctors to you. Because you are going to say, oh, no, everybody's great. Okay? So your goal is always for the patient to be able to open up. And in this case, when you're defending, the patient is thinking you are taking sides of the doctor and you don't like the patient. Okay? That is what it shows as. Next is requesting an explanation, like why questions. That is already wrong. Asking the client to provide the reasons for their thoughts, feelings, behavior, and events. Why do you think that way? Why do you feel this way? Describe what you were feeling just before that happened. So you don't ask the patient, why did you do that? Okay. You can ask the patient, what led to it? What was the reason? Okay. So there is a way of asking this. We just don't directly ask why questions. Indicating the existence of an external source of power, like, oh, God's gonna fix everything. Maybe your patient does not believe in God. Like this modernized scientific world, Gen Z generation, many people don't believe in God. Many people don't believe in higher power. People believe in something else. So you can't say things like that there is an external source of power too. Attributing the source of thoughts, feelings, and behavior to others, or external source of power, or that other people made me do these things. So what makes you say that? What made you so angry last night? So these questions are actually not wrong. I don't know why I wrote them here, but these questions are not actually wrong. But external source of power will be like somebody else is responsible for the things you said. Okay. Or someone else made you angry. So this is right. You became angry when your brother insulted your wife. You can't say that because, your brother was talking bad about your wife. That's why you did that. It's okay. Because Ultimately, who was angry? The patient was. So no, sometimes people say, "Oh, my husband is an amazing guy. It's the alcohol which is bad." That is a very big red flag. Ultimately, who was drinking the alcohol? The person. So that is what the meaning of indicating the existence of an external source of power. Oh, he's amazing when he's not drunk. When he's drunk, he's the same person. How can you differentiate the person just because somebody was drunk or somebody took drugs or anything? I'm just giving you a random example. Belittling feelings expressed. What is the meaning of that? When the nurse misjudges the degree of the client's discomfort, a lack of empathy and understanding may be conveyed. Client will say, I have nothing to live for. I wish I were dead. And the nurse says, oh, everybody feels down sometimes. I feel that way myself too. Because that makes the patient feel like, oh, okay. So my feelings have no value. Everybody feels that way. So I don't have to feel bad about it. So that just means that the nurse is saying your feelings have no value. But it does, right? So what should we say? We have to explore, we have to ask the patient about more how they're feeling. You must be very upset. Tell me what you're feeling right now, to express their feelings. Making stereotyped comment. Do you guys know what a stereotyped comments are? No? If someone asks you, hey, how are you? You say, sorry, Mel?
It's like generalizing, like attaching it to someone that defines, like, if you're an Asian, it's something like that. It's stereotyping.
Stereotype is like something that's cliche. So somebody asks you, if you meet somebody on the road, hey, how are you? Oh, I'm good, thank you. How are you? But are you actually good? It's just like a statement we all say, right? When someone says, hi, like on the road, you meet someone and people ask you, hi, how are you? And you're like, I'm fine, thank you. How are you? Right? So that's like a cliche statement. Sorry? Shalom?
Untrue statement.
Not necessarily untrue, but it's just like a thing that has been used a lot. Like people use it. Like it's just like a band-aid for everything. Okay. So for example, hang in there, it's for your own good. But that closes off the conversation. When the patient says, oh, I feel really low at this time, I don't know if I can do it. And you say, hang in there, it's for your own good. Rather than that, you should have asked the patient, you're having a difficult time. How can I help? Okay. So rather than trying to just close off the conversation by saying, oh, you're going to be like, hang in there, it's okay, or all those things. So I can say empty comments. Like, don't give empty comments that like you're just saying it for the sake of saying. Those are known as stereotypical comments, like, oh, it's, yeah, I know, like that, like empty kind of statements. Using denial, when the nurse denies that a problem exists, he or she blocks discussion with the client and avoids helping the client identify and explore areas. If the patient says, I am nothing, and you say, of course you are something. Everybody is somebody. But you didn't address why is the patient saying I'm nothing? Right? Like why if I tell you I am nothing, what do you mean? What's your reason for saying you're nothing? So you actually need to know more rather than saying, of course you are something, everybody is somebody. Okay. So better to say you're feeling like no one cares about you right now. You can ask the patient, like, is that how you're feeling? When patient says, oh, I'm nothing. Actually, think about it. When sometimes we fight with our loved ones and say, I have no value in this house. I'm nothing. And they say, of course you're something. I'll be like, oh my God, that's not a good answer, right? What are you thinking? That you feel like that we don't care about you? Is that what you're feeling? Because it does have a meaning behind it. Next is introducing an unrelated topic. What does that mean is non-therapeutic. Why is it? Because you're just adding a different topic and changing the subject. So changing the subject causes the nurse to take over the direction of the discussion. Patient is talking about something else and you're asking, what did you have for lunch? So patient says, I don't have anything to live for. And the nurse says, did you have visitors this weekend? How does that sound? The patient said, I don't have anything to live for. Better technique is the nurse must remain open and free to hear the client and to take in all that is being conveyed, both verbally and non-verbally. So all these therapeutic and non-therapeutic techniques were from this book, Townsend. Okay. Next, we're going to do questions and see how you can apply it. So you guys can, Dheeraj, can you read the question for me, please?
A client on the locked unit of an inpatient psychiatric hospital says to a nurse on the night shift, during the day, they made an exception and let me go to the cafeteria. You are my favorite nurse. I know you will be nice to me and let me go get a snack again. What is the best response by the nurse? First one, I guess the day shift staff needs to be reminded of the rules. Second is the cafeteria is not open right now. Third is what do you want to get from the cafeteria? Fourth one is you do not have privileges for leaving the unit at this time.
So because all of you are internationally educated nurses, I wonder if you guys are going to pick the right answer, but I will explain you what is the answer and why is that right. I hope someone can pick up the right answer. So I have two answers for now. Okay. Okay. Guys, please mute yourselves. Okay, so I think I got answers 1, 3, and there's only 1, 4, right? Kiran wrote the fourth. Kiran and Gagan too has written 4. And Alexandra wrote 4. Most of the people are writing 3 and 1. Krishma wrote 4 too. Okay. Okay. So, Krishma, why did you write answer 4? If you can just explain me, please. If you are at work, then that's okay. Because I don't know. Krishma, can you answer or I can't hear you though. Can anyone hear Krishma? Because she's on mute, but sorry, Krishma. Okay. Alexandra, you wrote 4 too. Why? What's your reason for writing 4? And what about other people? Other people have decided not to answer. You just want to wait for. Oh, Alexandra is in the train. Okay. Kiranjot. Kiranjot, why the answer 4? I don't know if she can answer. She's usually at work too. Okay. All right. Let's move on to what about others? I only have few answers. What about other people? Like you guys are just gonna wait for the answer. The nurse should present the reality to the patient. Okay. Rikisha, you can't write 2 answers, 1 and 3. That's not an option. Only one option is correct. Jaswinder Gill, why 3?
Because this is giving the patient to explore more, like why actually he wanted to go out and what he wants to get. And it's going to give him option also to speak up more about his feelings, like why he wants to go out.
Okay. Mane, you also marked option 3. Why? Thank you, Jaswinder.
I believe it's like knowing more about the patient, like why does he want to go and what are the main reasons, because the main thing is he's asking again to go out. So why at this time he wants to go? So
Okay.
exploring.
Dheeraj?
First of all, I choose the first answer that I thought like it's against the rules. But then I thought the third one is the correct answer because we have to think for the patient first.
Okay, Luis.
It's about exploring his needs.
Mel.
It's more of like digging what's the purpose of why you want to go to the cafeteria. You're not judging anything, you're not saying yes or no. You just want to know more information.
Okay, thank you. Shalu, why one?
It's according to rules that the patient is in locked unit, so there is no any option to go for outside for cafeteria.
Sakshi, why three?
It's just because we are just about to know the patient. Maybe he's hungry or something, so that we could have help for him.
Okay, thank you so much, guys, for explaining. So I'm going to read the question again and I'm going to explain you guys some things. A client on the locked unit, there is a reason the patient is on the locked unit, of an inpatient psychiatric hospital says to a nurse on the night shift, during the day, they made an exception and let me go to the cafeteria. You are my favorite nurse. I know you will be nice to me and let me go get a snack again. What is the best response by the nurse? Okay. I guess the day shift staff needs to be reminded of the rules. How do you know that they did not? How do you know the patient is telling you the truth? I don't know. The patient is probably manipulating me. Okay, I can believe the patient is telling me truth, but how can I choose? I guess the day shift staff does not know the rules. They know. Day shift staff knows the rule the most. Okay. The cafeteria is not open right now. He knows. He will tell you, oh, I just want to go out, even if the cafeteria is not open. What do you want to get from cafeteria? How does that help you? Many of you chose option 3, right? So I'm going to tell you one thing. When the patients are on, I have worked night shifts on forensic rehabilitation. So there is a consistency. There are rules on the unit and there are consequences. Okay. Because these patients need to learn how to follow the rules, because that is why they are on a in a psychiatric hospital. We are helping them understand these. So I used to have a patient. So we have TV on psychiatric units, and the TV is allowed only until 10 o'clock. Okay. And we have a unit with the like all the mirrors because it's a safe unit. So we are all inside that unit. We mostly stay inside those mirrored thick glass doors and stay inside. And where do you think is the control of that TV is? Where would that? In the nursing station. As soon as it's 10 o'clock, 5 to 10, I go outside. I tell the patient, I'm going to turn off the TV at 10 o'clock. It's going to be off. I'm making no exceptions. Why? If I make the exception, a patient like him is going to go to the next day and tell the nurse, oh, well, my nurse made an exception. So in psychiatric units, it's very important to stay consistent. You have to play by the rule. If it says that everybody has to be back by 4 o'clock from the smoke break, if you come back 5 after 4, you will lose the next smoke break. That's how strict it is. And there is a reason for that. That is why we don't make exceptions. So you have to remind the patient, you do not have the privileges for leaving the unit at this time. You're doing nothing wrong in reminding the patient. So what do you want to get from the cafeteria is a different topic. But the first thing I need to tell the patient is, you do not have privileges for leaving the unit at this time. If the patient says, oh, but I'm hungry, I can get you a snack, because we have fridges, refrigerators on the unit. We get snacks at night. they are on medications, they can feel hungry at night. So we usually have apples, milk, water on the nursing station. And it's because I've worked the night shift, so I know exactly what happens at nighttime. Sometimes we have sandwiches because there is note saying that this patient gets really hungry at night. So please give the snack to this patient. Oh, this patient is diabetic. Maybe their blood sugar level is going to drop at night. So give them this sandwich. So they get all this food from the dietary and we keep it in the fridge and it has their names on it. Does that make sense for everybody? Okay.
Yes.
Okay. So what do you want to get from cafeteria does not help me because he wants to go. That's my concern. Not what do you want to get from the cafeteria. Even if it tells you, I want to get a burger from the cafeteria, what can you do? How does that help you? Nothing. You can't get him a burger. It's the time. It's the night time. And he's trying to manipulate you because he's telling you, the nurse made an exception. You are my favorite nurse. You will be nice and you will let me go. He's trying to manipulate you, right? Do you guys understand that? Everybody's good? All right. So answer is 4. You do not have firm, consistent. Okay. So I always tell this to my students. Being professional is always nice. Being nice is not always professional. So if you're like, oh, I'm going to be nice and I'm going to let him go, that is unprofessional. You have, breached a boundary. You have not followed the rules and you will be written up tomorrow because if this patient goes out at this time and hurts someone else, who is responsible? You are, because this is a locked unit. Why did the patient go out at this time? Are you guys understanding? Okay. All right. Sakshi, can you read the question for me?
Yeah. The healthcare provider has just informed a client who has diabetes and chronic kidney disease of the need to start dialysis. The client tearfully says to the nurse, I don't know what I'm going to do. Everything was so overwhelming before, and now there's this. How should the nurse respond?
Okay.
You can
Yes, I
cry
think you
and
guys
get
can
it
do.
all out.
Mm-hmm. Go. It's okay. Yes, please.
Sorry, should
Yeah,
you can cry
read.
and get it all out. I will stay with you. You have deal with diabetes. You can conquer dialysis. You sound very discouraged and frightened. You still have a lot to live for. Think about your family.
Good. It's a good question, right? Sounds really good. You guys can do it. And the goal is not for you to tell me the right statement. The goal is why other 3 are wrong. So when you're picking the option, I'm going to ask you, whichever you pick, why the other 3 options are wrong. Okay, so I got lots of answers. Where are the students going? Why is the number going down? Lots of 3s. And I think, Gagan, Gagan, why 1?
Because the nurse is staying with the patient and trying to blubber out everything out, so the patient is not keeping anything inside. And third cannot be because I don't know, it's according to me, because it's just showing that you are discouraged and you are frightened, but we are not giving fulfillment to the patient.
Okay, now let's see people who have done 3, what's their thought process? Binder, why 3?
I guess by saying this, nurse is doing clarification and validation to what he's telling the nurse. So once he open up with this thing and nurse says that you sound very discouraged and frightened, the patient might feel that there is somebody who's listening to her, and he will open up more further ahead with her.
Okay. Shafika, why 3?
Yes, ma'am.
Why
Yeah.
did you pick 3?
Ma'am, like she's acknowledging her. Like, yeah, this is something,
That's the right answer. Yeah, that's right. So answer is 3. Why is 3? Of course, 1, you can cry and get it all out. I will stay with you. She can cry, but you're not giving her a platform to talk about it. You're telling her you can cry and get it all out, but what about talking? What about acknowledging? So first of all, I don't know what I'm going to do. Everything was so overwhelming before, and now there is this. Okay. So the patient is telling you, I don't know what to do. What am I going to do? Where is it saying that the patient wants to cry? Maybe I don't want to cry. Maybe I just want to talk about it. So you're judging me that I want to cry. Maybe crying, encouraging crying helps to, it conveys concern that if you want to cry, you can cry with me. It does show concern, but it does not encourage discussion of feelings. So your goal is for the patient to open up and discuss their feelings. You have dealt with diabetes, you can conquer dialysis is false reassurance. You sound very discouraged and frightened. And she's like, yeah, I will tell you one trick, I also used to feel like, oh, I'm so sorry you feel that way. If I tell someone you sound frustrated and what is the answer? What is the answer you get from people when you tell them you sound very frustrated? Yes, I am frustrated. They did this. They should have done this. They should have done that. Have you heard that? Have you ever tried this sentence on someone?
Yes, ma'am.
If somebody tells you you sound upset, you're like, yes, of course I'm upset. They did this to me. What does that mean? That you are acknowledging. You are saying, yes, I think you sound upset. That must be frustrating. Right? And the person can be like, yeah, that's upsetting, that's frustrating. So you open up the door for more feelings to vent. When you say you can cry and get it all out, I will stay with you. It's sounding good that you're gonna stay with the patient. It's nice, but it's not the best response. The best will be you sound very discouraged and frightened because she is frightened and she is discouraged. You still have a lot to live for. Think about your family. This is not the right time to talk about this. It's a cliche, right? This is a cliche. This is a stereotypical statement. Do you guys believe, understand that? That this is a cliche statement. Are we good?
Yeah.
Okay. All right. Any takers? Anyone wants to read the option? Nobody. Let me see people who are off the camera. Amandeep, can you read?
The nurse is caring for a client with a terminal illness who is expected to die during the shift. The client's spouse states, I hope my spouse can live a little longer. Our anniversary is in 2 days. Which of the following responses would be appropriate for the nurse to make? Tell me about your favorite anniversary memory that you shared. That would be very special, but please understand that it may not happen. We never know, death happens in its own time, despite what we may want. You should be grateful for the time you and your spouse have shared shared together.
Okay, thank you, Aman. Okay, guys, let's see the responses. I got all the options, I think. 1, 2, 3, 4. Okay. Okay. Dheeraj, why 3?
Because we are assuring that like death
That he's
happens
not gonna
anytime.
die? Are you leaning towards false reassurance, trying to make her feel better?
I'm not sure.
That's okay. Okay. Sumanjit, why 3, Suman? Sumanjit, are you there? I don't know.
Yes, ma'am.
Okay. Why 3, Suman?
Because we don't want to be false reassurance.
So you chose 3 and you're telling me you don't want to choose false reassurance. Where is the true reassurance in 3? How would this is appropriate? So you're looking for an appropriate response by the nurse. What is the connection of 3 to what the patient spouse is saying? Parallel, why 1?
Because it's not 2 and 4, which is obvious. It's not 3 because she's saying we never know, which is like false reassurance. Like we never know what can happen.
Yeah.
Tell me about your favorite anniversary is giving her chance to talk about more what she's talking, like what she will be
Like
missing.
positive things to look at, what she has, right? So you are like, if you give her, you should be grateful. You are discouraging her thought process. Like, oh, you know what? You should be grateful. Like, you should just be grateful. You should be thankful. You are disapproving of her feelings. You will never know, death happens in its own time. Why would we say that? Like, we are telling her, oh, maybe he doesn't die. Maybe he won't die. That's not true, right? That would be very special, but please understand that it may not happen. I know it's reality, but it's not the appropriate response to say to the patient's spouse. The appropriate response is, tell me, what was your favorite memory that you shared? To decrease the anxiety and to decrease the suffering, explore the positive feelings with the patient's spouse. Anyone has a question about this? Okay. Kiran, you picked option 2.
Yes.
Presenting reality. Here, presenting
I've
reality is non-therapeutic. Parag, do you have a question? Your hands up.
Yes, I just wanted to ask if this was a situation in real life and we don't have the multiple choice question, these multiple choices, would it be appropriate to say, how does that make you feel?
I will still talk about like for me, when I am doing these questions, I am actually thinking about the real life scenarios because I work in mental health. For me, this is actually the right option. I will bang on choose this, that yeah, tell me about your favorite memory with the person because you're losing that person. You want to cherish. You guys remember when you read eulogy at death, you want to remember the good parts in that in a difficult time. Sometimes people use humor to talk about that person, that oh, you know, he used to be like that, my dad used to say this to me, I know he's not between us, this is what he would want me to do or something. So you always want to talk about the good things when people are so down, to actually you're talking about that person, you're talking about their anniversary in a positive light. I know she's gonna lose him, but those last minutes, at least she can feel like, you know, I shared such good memories with you. And that kind of gives her a closure that, okay, you know, he's gonna go. You can't control that. He's gonna die. You can't tell her that, oh, you know, he may not die. He may survive for 2 days, but he's gonna die after that. And the question says terminal illness who is expected to die during the shift. Okay, so many times we get patients who actually do die during the shifts. So you can't give them any other. If I am the nurse working, my answer will stay favorite anniversary memory, or tell me about good, like what you guys used to do. How did you guys meet? Questions like that, because we know he's gonna die. Like I'll say, what? How did you guys meet or something? Okay. 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 Sarnia, can you read me this question, please?
Yes, ma'am. An elderly client at the end of life is visited by family members. One begins to cry and asks the nurse, "Will you please stay for a few minutes?" The nurse has other clients to care for as well. Which statement by the nurse is the most helpful? Option 1 is, "I'm busy right now, but I can stay for a few minutes." "I can call the clergy to come sit with you." "I can stay and sit with you if you would like." "I don't think I should interrupt your family time."
Okay. Okay. So guys, write the answers in the chat. Let's see. Very fast answers. Okay. I just got few answers. That's it. Everybody kind of just stopped. Okay. Tessa, why one? Jaswinder one. Okay. Dheeraj, no. Man is one. Mandeep is one. Okay. Okay.
I choose one because I am busy is presenting reality, and staying a few minutes is not bad because you can still stay a few minutes versus the other options.
Where does it say
Clergy
you're
is
busy? Where did the question say you're busy? Maybe this is your only patient. Where does the question say you're really busy?
you have other clients to care for.
Okay. If you tell me I'm busy right now, but I can stay for a few minutes, how am I gonna feel? Oh my God, she's busy, but I'm making her stay. Guilty that I don't deserve your time, but you're just doing me a favor. Do you know what I mean? Telling family members that a nurse is busy is not a helpful response. They will feel guilty of asking you that we need your time and attention. Okay. You can always ask your co-workers to help you out. I know real life, it may not work, but in NCLEX, it will work that you will tell your co-workers, hey guys, please help me. My patient is dying and they want me to sit with them for a few minutes. Think about it in NCLEX world. What would you do? You will sit with the patient. The patient told you they want to sit with you. You will sit with them. You will not tell them, I'm busy right now, but I can sit for a few minutes. I know you're trying to present the reality, but it's not the most helpful response because it makes the patient's family feel guilty. Oh my God, we just asked the nurse to sit. She's so busy. And think about it that the family members are talking among themselves. Why would you tell the poor nurse to sit here? She's so busy. Oh my God, you shouldn't do that. So that makes them feel guilty. We will say, I can stay and sit with you if you would like. You are offering that. Okay. They said, will you please stay for a few minutes? And you said, I'm busy right now, but I can stay. If you are going to stay for a few minutes anyway, you don't have to say I'm busy. Just stay for a few minutes and then it will be like, I will be back. I'm just going to go see my other patient. But you don't make people feel guilty by just staying with them. Does that make sense to everyone? Most of you have picked the option 3. But I do want to know, like, if you picked option one. Mandeep, you picked option one.
My reason is also the same because it is a present situation that was written. The nurse has other clients to care for as well. Means we can tell the family members that that I am busy, and but I can stay. Even I am acknowledging you too. You are asking me for a sit, so I can sit for a few minutes too.
But we have to choose a response which is most helpful. So this is good. But what about this one out of these two? Of course, you're not going to do this at this time. This is wrong because they are asking you to sit. So it's not interrupting family time. So if you have to choose between 1 and 3 and you're choosing a response which is most helpful, which is going to help the family the most, which one would it be? I can stay and sit with you if you would like.
For this, I think that I can't give letting other patients. Yeah.
You can always
Means
ask
the
your
other patients are
coworkers to
important.
help. You
Yeah.
can ask your coworkers to help you. This is elderly client at the end of life is visited by family members. End of life is a very important component of NCLEX. And you can see one begins to cry and asks the nurse, will you please stay for a few minutes? What is most helpful? Oh, you are crying. I'm busy right now, but I'm going to stay. Rather than that, I can stay and sit with you if you would like. Okay. This is like a distractor that you have other clients to care for. You always have other people to care for. Okay. So during the end of life process, the client and family members typically go through several emotional stages, each requiring therapeutic communication by the nurse. The nurse has a very active role in the end of life care. So we provide them, the few minutes of attention and time and validate their needs and feelings. So because now the family is also your client. Does that make sense? It's not
Yeah.
only the patient's family at the end of life too is your client too. Okay. So in NCLEX, you have all the time in the world that you want. Trust me, when we have end of life care, if I'm working as an RN, end of life care, I am going to take over that patient entirely because the family is going to have so many questions and you want to provide the support and make the process as easy for them as possible because they're already going through so much. They're losing their loved one. Okay. Be empathetic and think about it. If I have a loved one and I ask the nurse, can you stay with me for a few minutes? And I'm crying. And you tell me, I'm busy right now, but I can stay for a few. I'm busy right now, but I can stay for a few minutes. I'm going to feel guilty that why did I even ask you? I shouldn't have asked you. You are busy, right? So what did it become? It is about you now as a nurse rather than about me and my feelings and my loved one who's dying. Does that make sense? So it's about the perspective, how you have to visualize the things. Okay. So this is our last slide. I do have like questions after this, but this is a very important slide and I want all of you to pay attention to this. I know it's very let me see the questions. Maybe I won't do this slide because it needs a lot of attention. Okay, I will do it when I teach you the other topics. Let's do a couple more questions. I have 3 more questions and then we'll wrap up. Okay. Okay. Harvinder, do you want to read the question, please?
Yes, ma'am. A client states, I just don't know what to do about this situation with my parents, and the nurse replies, I am sure you will do the right thing, which summary is true regarding the nurse's response. Option first is the nurse has encouraged exploration of the client's situation. The nurse has shown interest in the client's concerns. The nurse conveys empathy toward the client and promotes self confidence. The, the response evalu- the response devalues the client's feelings and gives false reassurance.
Good. So many of you are writing 4. Questions like these, this is a very easy question because now you understand everything. Questions like these, you need to learn the cluster. So the nurse has encouraged exploration of the client situation is a good statement. The nurse has shown interest in the client's concern is a good statement. The response conveys empathy toward the client and promotes self-confidence. True. But this is not what it's doing. I'm sure you will do the right thing. Stereotype, false reassurance. How do you know the patient's going to do the right thing? We don't know. So you can cluster that all 3 here point towards good. So that means it can't be the answer. They all are clustered together. They are friends with each other. So you got to pick the opposite of that, which will be option number 4. Do you guys understand what I'm trying to say? Sometimes all 3 options are conveying the same message. The only option that is opposite to all 3 is the right answer. And Shafika, you picked 3. Okay. All right. Okay, let me see.
Yes, ma'am.
Shafika, it's okay. It was last question. I moved on. So it's okay. Sumanjit, read the question, please, Sumanjit. Just Kirat, you're gonna read the next question.
A nurse is communicating with the client on the acute mental health facility. The client states, I cannot sleep. I stay up all night. The nurse responds, you are having difficulty sleeping. Which of the following therapeutic communication techniques is the nurse demonstrating? Option A, offering general leads. Option B, summarizing. Option C, focusing. Option D, restating.
Thank you, Suman. Okay, good. So many of you are answering D. That is the correct answer. Restating. Whatever the patient said, the nurse is saying it again. Why not focusing though? Why aren't we not choosing focusing? What is the difference with focusing? Sarabjot, why not focusing? Why didn't you pick focusing?
Because there's only one statement. There's not much to find out what I have to focus on.
Exactly, that's the right thing. There is not like the patient is not giving you 3, 4 concerns and you focused on one. The patient just talked about sleep and you talked about it again, restating. Okay. Offering general leads are like, what do you want to talk about? Summarizing is in the end. When I summarize, you told me a whole story and I summarize. Focusing, when the patient talked about 2, 3 things and you focused on one of them. Last question of the night. Ishi, can you please read it?
You told me. A nurse is communicating with a newly admitted client. Which of the following is barrier to therapeutic communication? First, offering advice. Second, reflecting. Third, listening attentively. And fourth one is giving information.
Before you even read the options, everybody's just like, because everybody
Yeah.
knows, right?
Yeah.
Okay. Okay, I think I don't have to like again, if we cluster, reflecting is good, listening attentively is good, giving information to the patient is good because you have to give information to a newly admitted patient. You never offer advice. Okay. All right, so this is the end of all the next will be defense mechanism. And I will not be teaching them today, but the presentation is up. I think there are defense mechanisms come in the exam quite frequently, so I don't want to just teach them today. Okay, anyone has any questions from today's lecture? Harvinder, you pinned yourself, your phone. I don't know how you did that, but you did. Okay. All right. So, any questions from today's chapter that you guys may have? How do you feel about it? Like, I want to know. So, I'm going to be here for the next 5 minutes. I want to know how much did it help you to understand how to answer questions? How was your experience? And I want to know the feedback so that I know what else can I, integrate into this to make it even better. Nobody's gonna talk. You're back. You guys don't talk. Like I had all the. Oh, just Kirat, I was gonna ask you a question. I forgot. Like it was your turn, but it's okay. Narrow escape. Next time. So, how do you guys rate yourself about communication skills and therapeutic communication? You think you learned it from a different perspective, and you may be doing questions, and you're like, okay, yeah, I never thought of like that. I have like 1, 2, 3, 4 hands up, and oh, Mandeep. Okay, Sakshi, your hand is up.
Yeah, actually, I just want to tell you that it's really nice for me, like understanding the questions, and after listening to the topics, and then when I go to the questions, it's easy for me to grab what is they asking and how to choose the options as well.
Thank you so much, Sakshi. That's really beautiful feedback.
Yeah.
Thank you so much. Tessa, your hand
Thank you.
is up too. Thank you.
So for me, it was a bit overwhelming to, to discuss all of the new um, therapeutic communications and with the mentally challenged patients. So I got confused a little for the question that I got incorrect. I think I overthink it, but after you explained everything to me, I realized I should have known this answer, and every point had it brought back, like, of course, the patient, a family is important, and at that time it's very important to spend time with that patient. The others can be less priority. If there's a patient that needs, you could have help with from your other class, your other nurses or so,
Also,
but that moment is
yeah, Tessa, I want all of you to think of like end of life care patient is equally important as an ICU patient, because now you have more patients. You have the patient, you have the family, and they are grieving. So it becomes even more important. So you have to make them feel that their patient is worthy of your time. It's not just because somebody is dying doesn't mean, oh, you know what, that patient is dying, room 10 is dying, you don't have to go there. That's not how it should be. I know that's how people feel, that, okay, room 10, he's dying, why do I have to go? But think about it. That's the last few minutes of that person's life that you are with them for. I know in real life it's really, really hard for us to spend time, but trust me, if you work in a long-term care home or in a hospital too, they have a special cart. They have their programs for the end of life care. It's so, and the family will have like a coffee cart, there is snacks on that cart, and there is a special recreation team who's assigned to that patient so that the patient is never alone because they're dying. Okay, so I'm sharing with you the real life experiences so that you guys can able to understand what is the value of a patient who's dying, end of life care. Okay. All right. I have so many hands. Thank you, Tessa, for your feedback. Sakti, I don't want to mispronounce. I'm like so bad. I'm sorry if I mispronounced your name. Did I mispronounce it, Sakti?
Hi, ma'am.
Hi.
How are
Did
you?
I I'm good. Thank you. Did I mispronounce your name by any chance?
No, ma'am. Siva Malini, my name. This is my husband name.
If you guys are going to bring the laptops of your husband and sons, how am I going to? Okay. All right. And
Yeah, thank you so much.
Yeah.
Thank you so much, ma'am. This is a first class. I
Oh,
can
is it?
understand everything. Yeah,
Oh, thank you.
I
I
can
didn't know.
understand everything.
Honestly, most of the people are hiding behind the name, so I don't know. But thank you so much for joining, and I appreciate your feedback. Thank you.
Thank you so much, ma'am. This is my first class. I can understand everything, ma'am. Thank you
Oh,
so
that's so
much.
nice. Thank you. You guys can tell her she can join, right? Okay. Okay. Thank you. Thank you so much. Ashmi, your hand is up too,
I
Ashmi.
just wanted to share one of the experience that I personally did. So last time I didn't attend your this therapeutic communication class. So I was in second year of nursing school, and in that second year our major was mental health nursing. So back home, like I think it's not my personal experience as well. Like back home, we are never taught about what is therapeutic communication, like how to approach a client. In second, in second year, I still remember we have to do the mental health assessment to three of the client, and I don't remember the diagnosis of one of the client, um, and later on, I got to know that she was from a very wealthy family, and it was a private asylum, and I don't remember. It was maybe third or fourth day. So I directly asked her in Nepali, like we call mentally ill patient a pagal. I believe in Hindi
Me
also,
too. Yeah.
you guys call the
Hindi.
same. So I directly asked her, "How did you become pagal?" And
Oh.
she replied, "Why would you call me pagal? Call me mentally ill patient." I was so amazed. Like that was one of my, biggest experience in nursing field that okay, because I was never taught about it, like how to say. And back home, like every time I remember, if someone is talking about suicide, we were always said, never ask why, never ask what's happening. We were taught like, don't ever talk about it. So I came here and then I realized, okay, this is something we have to talk about it.
Mhm.
So yeah, this is the experience when I got to know about this therapeutic communication today. So yeah, I just wanted to share.
Oh, that's really nice, Ashmi, and that's so true. And I have had students when I'll do questions on suicide, and the students like, oh, when you ask the question about are you thinking of killing yourself, you are actually introducing the idea into the person's mind. No, that's not what it is. You are actually asking them loud because suicide is a cry for help that I am unable to control my circumstances. And I think, and even the interview I showed you guys asked that, have you thought about that, you should just put it to an end by, finishing your life. So even the doctor asked that question in the interview I showed you with Andy, and he's like, no, I didn't think about that. So it's very real. And I have seen patients with depression after they have recovered, and you will be surprised. You're thinking, why are they behaving like this? But nobody will ask a question. If someone has a cast and they are walking on the, what do you call them? The crutches, nobody will question that. People will be like, yeah, the person is sick. But when somebody has mental health issues, they're not wearing it on their face or anything, right? So the goal is to be kind and non-judgmental and empathetic. And I talk to so many of you many times, and you call me and we talk about things. Everybody's going through something. It's not easy to, like, especially most of us are immigrants. It's very hard, right? So the goal is to become a registered nurse, to become a nurse that people look at you and feel, oh my God, she's such a beautiful human being. Okay, that's the goal, to be kind. And I always tell you, like, being nice does not count, because when you're trying to be nice, you may become unprofessional. You may do something that you're not supposed to do. So always try to stay professional. Professionalism is always nice. Okay? That is my personal experience. I want to share with you guys one thing before I know I have two more hands. I was in Toronto. I came in like 2013, I believe, 2012, 2013. And like the little kids, I'm from India, of course, if you can't tell, like, oh my God. So I'm from India. So there's little kids, like 2, 3 years old kids, right? So we were getting down from the bus, and there was a kid behind me, and his dad was behind him. So the kid was on the second step, and the kid was struggling. So I picked up the kid and put them on the sidewalk. Oh my God. His dad was so mad at me. so mad at me because I was being nice. I'm like, oh my God, the kid was gonna fall. He was like, no, my kid is trying to learn independence. You think I couldn't hold my kid? My kid is trying to learn independence, and you picked up the kid and took such an important moment away from my kid. That's the day I'm like professional, like nothing, never, don't, no, don't touch. But I was like, I was very new to Canada, and I was like, oh, you can touch, like and here you're not allowed to touch the kid. And even for my own kids, I have a 6-year-old daughter. I don't want, like, because you don't know if you are living next to a serial killer or something. I don't know. So, that's my experience too. So we all learn, like Ashmi shared hers, I'm sharing mine. So I have two more hands up and many people are leaving. So, Parul, what's your question?
Now learning from you, I think I have realized that I made a mistake in past. When I was leaving my job, it was probably my last day at job. And I was a primary nurse to a patient, and she was in tears and upset that I was leaving. And I made a comment that, oh, the next nurse that's taking over, she has like way more experience than me. So I think I was playing like defense when I said that. So I want to know, what could I have said at that moment?
So you should have explored the feelings because the person is upset that you're leaving, and also think about the stages of I told you, right? Orientation, working phase, termination. Patients can cry in the termination phase. You just have to accept it. Of course, you can't, like if it's 3 p.m. and your shift ended, you can't stay there until 3:30 just trying to be like, oh, you have to stay practical and professional. But of course, you can say, I know it must be very hard for you that I am leaving. And explore a little bit more. What are her concerns? What is she thinking? Maybe she's connected to you, but that's when it talks about the boundaries, professional boundaries. So it's a professional relationship. It was going to end. It's not a personal relationship. You are not my aunt or my cousin or anybody. So we have to set this boundary in the beginning. So I will tell you, when I go to my patients, I tell them, hey, my name is Sarabjit, and the shift starts at 7 o'clock. I'm going to be your nurse until 3 p.m. Okay. So anything from 7 to 3, and I will be taking a half an hour break, and someone else will be covering me at that time. But if you need me, please let me know. My name is Sarabjit, and I write on the board, your nurse is Sarabjit, 7 to 3 p.m. What am I doing? I'm establishing the boundaries. Like, don't disturb me after 3, I'm done. Okay. But I'm being professional, and that's the true thing. Even the hospital can't question me. Why did you tell the patient that? But if there is a safety issue at 3 o'clock, at 10 to 3, he fell on the floor, I'm gonna stay. And I want to be paid too. So that's different. Okay. All right. Manya, your hands up. You'll be like, oh my God. But trust me, don't let the employer not pay you if you're saying, I know some of the employers try to play this like, oh, you were not supposed to stay and stuff. So stay professional. If you're professional, call your charge or whoever. If you are the in charge, then it's different story. But call your manager or something and tell them, patient fell at 10 to 3. I have to document and I have to take care of this patient. So I will call you before I leave, or I'll send you an email. Why are you telling them? Because I want my time to be paid. This is my time away from my family. It should be paid. Okay. All right. Money.
I just wanted to say that maybe it's like very nice that you're explaining every option, that how it's not linked to the question. And that literally helped me a lot. Like it's improving my question and answering skills too. Like whensoever I'm looking up to the question, I'll legit do that. Like why it's not implying and why it's not getting to the answer. And I just wanted to thank you for that. Thank you for clarifying the options. It literally helped me a lot. Like I literally know how to choose the right one out of the whole loopholes.
That's
Thank you
really
so
nice.
much.
Thank you. Thank you. I didn't know like it was gonna be so beautiful to hear all these positive comments. I'm really grateful. Okay, so now you guys have off for 4 days. 3. I mean, like 3, I think. You guys can come for the webinar if you want to. I'm just gonna, it's gonna be boring. Trust me, I don't know if the people who are coming from outside, they're gonna hate me. But I want to talk about the, topics of syllabus. Nobody talks about the syllabus of NCLEX. So I want to talk about that, because you only find out about the syllabus of NCLEX when someone fails and they get a report and they're like, oh, they gave me all these areas. I was above, I was below. The link of that class will still be posted on your roster at the same time. You just have to click and join. You don't have to register. I know many of you registered, and Mona was just like killing me today. She's like, why would you do that? It got mixed up. I don't know how many people are coming from outside. It's all your students. So I took the link out. So, but the Zoom link will be on your, because you guys get the priority over everything. So we will have a good discussion. We'll talk about the topics, and it just gives you, even though you feel like it's boring, because syllabus is always boring. That's why people don't talk about it, but it will give you a direction that when you're studying, you will know, oh, NCLEX likes to ask question on quality improvement too. I should know what is that. Okay. So that's the purpose. Manya?
I just wanted to ask that if I'm not able to attend the
Got it.
webinar, would
Yeah.
the recorded video be uploaded?
Yeah, absolutely. There is no question. Any class, you attend it, you don't attend it, it doesn't matter, because even if sometimes we attend the class, what if you have to leave it in the middle? What if you're sitting at night and you're like, oh, I don't remember what was focusing, and you're like, okay, I'm just gonna open my video to see. So recordings have a lot of value, not just in terms of that, it's recorded and I can watch it whenever I want to. It's also 2 months down the lane, when you are doing questions on maternity, you're going to forget all about what I taught you. Just for example, right? You're going to go back, see what are the complications of gestational diabetes mellitus, and be like, oh yeah, now I remember everything, why the baby is large, or all these things. So recordings have a lot of value and they stay with you. So every class is recorded. I am losing a lot of people, so I'm going to let you guys go. Thank you so much and have a great night. Take care of yourself. Be kind to yourself. Self-care is very, very important. Please don't forget about yourself. You gotta take some time for yourself too. And yeah, just positive self-talk that, write your name and write the title and date it, please. Okay, just because there's no class does not mean we are not available. We are still available. You can text Mona, you can text me, you can text in the group. What's the schedule for next week? So next week, Monday, Tuesday, Wednesday is my class. So it's evening. Thursday, Friday, Alveen's class, so morning and evening sessions. I will post it in the group too. Okay, thank you so much, guys. Have a good night. Thank you.
Thank you, ma'am.
Bye, guys. Bye.